Farhan Abbas. Sir, I will be calling upon the next person, Dr. Gautami B. Dr. Gautami B, are you ready? Dr. Divya Rani. Dr. Divya Rani, please share your screen, please.
Hello, good morning, sir.
Good morning, Dr. Farhan Abbas. Are you ready?
Yes, sir. Can you just see my screen and my sir?
Yeah, put slide share.
Full screen, full screen, full screen. Make it full screen.
Yes, sir.
Start your presentation and timer will start. Funny, you take care of the
Yes,
time.
sir. Yes, sir. Yes, sir. Yeah, you can start, Dr.
Hi,
Muhammad
sir.
Farhan Abbas.
Yes, sir. Hi, sir. Myself, Dr. Mohammad Farhan Abbas. Today I'm presenting a case study from the application of latex fibrin for the repair of small impairing membrane central perforation. That is an alternative plastic. Introduction that impairing membrane separate the structures of the middle and inner layer, as we know, middle layer from the external environment. Impairing membrane perforation is a permanent abnormality of the past tense or past flaccida, most likely a result of earlier acute otitis media and earlier pressure otitis media with occlusion or trauma. Angioplasty is an operation in which reconstructive procedure is limited to repair of impairing membrane perforation. As reported in literature that there is a wide range of failure of myringoplasty, which may reach up to 40% in adults and 55% to the children. And repairing membrane perforation can be successfully repaired by a graft material. The commonly used graft materials are temporal fascia, pericordium, cartilage, and adipose tissue. These graft materials possess risk of thickening, resorption, and excessive thinning and myringitis. So there is need that these graft materials should be replaced by another graft materials, and one of the alternative methods is plasma. It is an emerging biotechnology in engineering and cellular therapy. It is a minimally invasive method to obtain the high concentrate of autologous growth factor, which can be easily and safely placed directly into the lesion cell. Platelet-rich fibrin was first described by Chopra et al. In 2001. Dohan et al. Conducted a detailed biochemical analysis in 2006. PRF consists of intimate assembly of cytokines glycanic structures like a protein and meshed within slowly polymerized fibrin network. These natural biometric data are cheaper, less invasive, and readily after which the correct cellular healing. It also has to cell proliferation, differentiation, and chemotherapy. Coming to objectives, okay. Okay. The objective of our study was to study the effect of application of platelet fibrin in the closure of repairing membrane central population of size less than 5 centimeters. The materials and methods. Our study was a prospective case control study with a duration of 6 months and sample size of 30. The source of data was the patients attending the Navodaya Medical College, Raichur, for the 6 months. Okay, these were the inclusion criteria and these were the exclusion criteria. And the methods of collection of data was patient who satisfy the above mentioned criteria for selection were taken as subjects for the study after taking informed consent and written consent. The selected patients were subject to clinical, audiological, and laboratory investigations. Detailed history of patients, general and clinical examination of patients were performed. Examination of the tympanic membrane under microscope was done and hearing evaluation was conducted, and also other routine investigations were done. And 15 patients underwent myringoplasty with freshening of margins of perforation alone using 10% trichloroacetate under local anesthesia in an outpatient basis. And the second group of 15 patients were also underwent freshening of margins with application of platelet-rich fiber under local anesthesia. And is also an outpatient in outpatient basis. Intactness of drum and process after 1 month. At the end of third and sixth month, audiogram was done on all of the patients. All of the patients were followed up to 6 months. Coming to the procedure, measurement was performed using a custom design measuring pick formed by the attaching 5 mm part onto the extremity of the straight pick with a 90-degree angle. Taking into account the diameter of tympanic membrane is 8 to 9 mm, the patients with perforation less than 5 mm were selected, and 1.5 mm larger, 1.5 times larger the perforation size of PRS was obtained. External auditory canal were packed with gel foam and ointment. Our observations were in there was significant change in PTA, that is pure on audiometric results, which were compared to the ABG. ABG is also significantly improved, and also there was okay. The distribution of patient based on the P share across two groups, PRF and non-PRF patient. The table shows that PRF patients, 13 out of 15 patients achieved a healed status, compared to the only 4 out of 15 patients in the non-PRF group. So this indicates the PRF group has a significantly higher rate of healing. In terms of persistent status, the PRF group had only 1 subject, while the non-PRF group had 5 subjects. For the residual status, the PRF group also had 1 subject, whereas the non-PRF group had 6 subjects. Okay. Coming to the results, in PRF group, complete of perforation was seen in 86.7% of cases, compared to the 26.7% of cases in non-PRF group. Hearing improvement was assessed by airborne gap benefit at the end of the 6 months post-operatively, with 12.97 decibels gains in PRF group and 9.88 decibels in non-PRF group, which was clinically significant. Coming to the discussion, myringoplasty is one of the most commonly performed procedures in otolaryngology. The purpose of closing chronic dry perforation depending are to improve hearing and to prevent middle ear infection. The alternative method can be used for the PRF. So it will have a medical cost benefit, and also there will be less invasive procedure. In our study, we have completed 2 groups of patients, PRF and non-PRF group, including 15% of cases in each group. At present, there is a very limited number of studies testing the efficacy of platelet-rich fiber on tympanic membrane perforation. So these are the few studies which PRF group was carried out. That is Sankara Narayana Manet et al. Concluded that the 95% of patients achieved the healed status compared to 72% of the patients of the non-healed status. Wahid et al. Also performed the same study. Mohammed et al. Mohammed MD studied the effect of PRF on healing of perforation. And also he got the same result. So Ozar, Adam, Gur studied the same and also got the same result. In our study in PRF group, complete closure of perforation was seen in 86.7% cases and 26.7 cases in non-PRF group had complete closure. Hearing improvement assessed by airborne drop at the end of the 6 months post-operatively. Coming to conclusion, in our study we found statistically significant results. These are
Good presentation, doctor. Sir, Nagaraj sir,
Thank you.
Selvaraj sir, any questions to the presenter?
Yes.
You didn't have any photo of your surgical results?
Yes, sir, I have the photos, but I'm not included in the PowerPoint. I can
Okay.
include
Okay,
later
doctor.
in
Okay,
the.
thank you. Thank you. Thank you, doctor.
Thank you.
Thank you.
Thank you.
Next presenter, Dr. Gautami. Are you ready?
Ready, sir.
Yeah, please share your screen.
Yes, sir. Good morning, sir.
Yeah, you can start.
Yeah. Today I am presenting about comparison between Manuka honey and baby shampoo nozzle dodging procedures after functional endoscopic sinus surgery. Introduction. Chronic rhinitis is a chronic inflammatory disease of nasal and paranasal sinus mucosa where symptomatology has continued beyond 12 weeks. In the past, the same was assumed to be 6 weeks, which was later changed in literature to 12 weeks. Acute rhinosinusitis is defined as an infection with a history of 7 days to 4 weeks. Acute exacerbation of chronic rhinosinusitis is defined as a condition which gets worse suddenly and then gets back to normal without any sort of intervention. The various causes of sinusitis ranges from rhinogenic, odontogenic, trauma and orbital causes. The management of chronic rhinosinusitis ranges from medical to surgical in cases of primary infections and a combination of both in recalcitrant cases. Manuka honey is made in Australia and New Zealand by bees that pollinate the native Leptospermum scoparium bushtree. That are found in Manuka honey are methylglyoxal, dihydroxyacetone, and leptospirin. Increase in concentration of MGO increases the antibacterial activity. It is at present being used against biofilm-producing bacteria, mainly in chronic rhinosinusitis. The first reported use of Manuka honey as an agent for nasal douching was in the year 2500 BC, and for wound healing wasn't until the late 19th century. Baby shampoo is an inexpensive, commercially available liquid solution containing multiple chemical surfactants that can act as mucolytic by reducing water surface tension and have the potential to serve as an antimicrobial agent. An ideal baby shampoo contains cocamidopropyl betaine, sodium benzoate, sorbitol, and sodium cocaine isothionate. The use of baby shampoo to act against the biofilms produced in the nasal cavity is being done from 2008 and has been extensively explained about in the new methods of surgical interventions. As of now, there is not much literature which compares the efficacy of the above mentioned agents as an adjunct for nasal cavity healing post-endoscopic sinus surgery. The modes of comparison used is Rhinosinusitis Disability Index. It was first formulated in 1997 and has been in use ever since. The aim of the study is to compare the efficacy of Manuka honey to baby shampoo in the management of the patency of the nasal cavity post-FIS. Materials and methods. Patients presenting to the outpatient department of otorhinolaryngology at a private hospital in rural South India with chief complaints ranging from nasal obstruction, nasal discharge, hypopnea, post-nasal drip, headache, facial pain, and related symptoms. The duration of the study was 12 months. Inclusion criteria are diagnosed with chronic sinusitis by means of diagnostic nasal endoscopy and computed tomography of the paranasal sinuses. Failure of medical management over a period of 6 weeks. Age group between 18 to 60. Exclusion criteria: space occupying lesions of nasal cavity and paranasal sinuses, deviated septum causing sinusitis, comorbidities like diabetes mellitus and hypertension, patients not willing for participation in the study. The diagnostic tools are nasal endoscopy was done under local anesthesia to rule out all other conditions which could hamper with the study like tumors and polyps. Non-contrast computed tomography of paranasal sinuses was done to look for mucosal thickening in the sinuses and obstruction of osteometal complex. Sampling. The sample size was determined to be 50 based on previous studies, and after using demographic calculations, the patients were divided into two groups of 25 each by a simple random sampling. From the first day post-surgery, individuals in Group A were given 5% Manukahani for nasal douching in both nasal cavities, and those in Group B were given 10% baby shampoo. The confidence level is about 95%. Assessment. All patients were enrolled in the study after taking adequate consent for procedure, administration of drugs, anesthesia, and usage of data for research. This is the rhinosinusitis disability index. There are several parameters like emotional, functional, and physical parameters. All the patients also filled out the 30-question RSDA form before surgery and then 8 weeks after surgery. The numerical values denoted is 0 for never, 1 for almost never, 2 for sometimes, 3 for almost always, and 4 for always. Thus, a maximum of 120 could be achieved for each patient. The nasal pack was removed on post-operative day, POD1, and was noticed once a day from POD2 to POD5. Management. Functional endoscopic sinus surgery was performed in all patients with the same instruments and by the same surgeon to prevent bias. Nasal pack was removed after 24 hours. Nasal douching was performed from POD2 to POD5 with a freshly prepared solution each time. It was carried out by the patient 6 times a day using 25 ml in each nostril each time. The patient was discharged on POD5 and was asked to then shift to douching with normal saline for another 5 days. Topical decongestant drops were not used in the postoperative period. In Group A, the symptom which improved the most was food does not taste good because of my change in smell. In Group B, the symptom which improved the most was straining increases or worsens my problem. In Group A, the symptom which improved the least was I feel handicapped, and in Group B, the symptom which improved the least was I feel restricted in performance of my routine daily activities. In both the groups, the p-value was found to be significant. Discussion. Bacteria exist in two distinct forms, biofilm and planktonic. Biofilm is the preferred state in which an estimated 99% of bacteria exists. Biofilms harbor a higher resistance to antimicrobials than planktonic bacteria. This resistance is a manifestation of physical barrier properties of the extracellular matrix, the induction of bacterial stress response, and coordinated behavior of the biofilm through quorum sensing. Nasal douching for clearance of infections, crusts, and debris from nasal cavities is an age-old method which has been performed in Southeast Asia for the better part of few centuries. The usage of Manukahani and shampoo as agents to clear the crust from the nasal cavities to prevent the formation of synechiae post any surgery of the nose has been performed since very long. Manukahani contain higher concentration of methyl glyoxal, contributing to relatively superior antimicrobial activity compared to other non-NGO honeys. Rhinosinusitis disability index was used to evaluate the self-perceived impact of disease in the both preoperative and postoperative condition of chronic rhinosinusitis patients. Another study performed in 2016 showed that in the treatment of sinusitis, the snort unit score improved in the group which has nasal douching with Manukahani. Culture nativity was also better in the same group as compared to saline nasal douching.
30 seconds left.
Manukahani offers several advantages: natural, non-toxic product, no adverse effects and allergic reactions, antioxidant and anti-inflammatory effects, availability over the counter, antibacterial effect against a wide range of bacteria, and decreased propensity for the development of resistant bacteria. These are my references. Thank you.
Where did you got your Manukahani?
Sir?
How did you got this Manukahani?
Yes, sir, we took it from online, sir.
Okay, thank you.
Okay, sir. Thank you, sir.
Dr. Divya Rani.
Yes, sir. Sir, can I get few seconds, few minutes, sir?
Dr. Divya Rani, we will go ahead with next presenter. After that, you can present. Dr. Saujanya.
Yes, sir. Good morning, sir.
Yeah, are you ready?
Yes, sir.
Yeah, please share your screen.
Yes, sir. Shall I start, sir?
Yes.
Morning, sir. My topic is correlation between radiological intraoperative findings in pharma type of chronic suppurative otitis media. Just a second, sir. Just a second. Not coming, stuck. So can I start now?
Yes.
So good morning, sir. My topic is correlation between radiological intraoperative findings in pharma type of chronic suppurative otitis media. Chronic suppurative otitis media is defined as a perforated tympanic membrane with persistent drainage from middle ear for more than 2 to 6 weeks. Due to location of the tympanomastoid compartment separated from the middle and posterior cranial fossae by thin partitions, otitis media has a potential for intracranial extension. To know the severity and extent of the disease, anatomical variations or destructions or erosions tends to avoid any complication in surgery. A CT scan of the temporal bone is must to proceed to any further with diagnosis and management of ear diseases. A high-resolution temporal bone computed tomography scan may provide additional value information in patients with CSOM that is unresponsive to medical treatment. The ability of HRC to depict the status of structure of the temporal bone that plain CD represents a major advance in delineating pathology before surgical exploration of ear in cases of squamosal type of CSOM or cholesteatoma. Nowadays, it's claimed that cholesteatoma as small as 3 mm in size can be diagnosed much earlier using HRCT. The purpose of this study is to compare the CT scan findings preoperatively with operative findings to know how much the surgeons can rely on the scans. The aim is to determine the radiological intraoperative findings of squamosal type of chronic suppurative otitis media, the objectives being to study the findings of HRCT temporal bone and intraoperative findings in patients with chronic suppurative otitis media, to observe intraoperative the sites of involvement of the middle ear and the mastoid ASL systems in these patients, find the difference between the radiologically and intraoperatively in patients with squamosal type of CSOM. The materials and methods, the study place for tertiary care hospital, the study period is from December 2022 to June 2024. Study design, cross-sectional study, and sample size is 50. Inclusion criteria, all age group with squamosal type of chronic suppurative otitis media was included. Exclusion criteria being mucosal type of chronic suppurative otitis media, acute otitis media, malignant otitis externa, congenital cholesteatoma, and previous surgeries of CSOM. Methodology, the present cross-section study is a comparative study of HRC temporal bone and intraoperative findings of CSOM, squamosal type, done in tertiary hospital during the period of December 2022 to June 2024. 50 patients were selected for this study. Patients with ear discharge were selected to detail his study and analysis. In all the selected cases of ear discharge, detailed history was taken, examined clinically, and subjected to detailed high resolution computed tomography of temporal bones. Preoperative audiometric evaluation with pure tone audiometry was done. Most of the patients were subjected to mastoid exploration depending on the indication. At the time of surgery, the operative findings were noted and recorded. HRT scan findings were correlated at the time of surgery and confirmed. Coming to the observation results, according to the distribution we have, the above table shows the maximum number of patients suffering from ear disease and underwent surgery fall equally in the age group of between 10 to 30 years, and the deafness disability correction was more in this particular age group. And according to gender, the male preponderance was more when compared to female. And according to the type of perforations like attic retraction, attic perforation, posterior superior marginal perforation, posterior superior retraction in past insa, oral polyp coming through TM, tympanic membrane, polyp in the external auditory canal, office posterior superior marginal perforation seen in 18 cases, and most it was correlated 100% correlated with the CT as well as on table. The cases of CSOM with or without complications were seen in 9 cases, with complications without complications was seen in 41, and all this was correlated with CT and on table during surgery. Complications CSOM included facial palsy, mastoid abscess, petrositis, labyrinthitis, meningitis, subdural abscess, temporal lobe abscess, labyrinthine fistula, lateral sinus thrombosis, aortic hydrocephalus. And the operations which we have conducted were like modified radical mastectomy and cortical mastectomy with tympanoplasty. Extent of cholesteatoma was in comparative correlation to on CT and in surgery. 46 cases were correlated, whereas 4 cases were not correlated when compared to on the CT as well as surgery. And bony erosion, the most common bone to be earliest bone to be eroded was scrotum, and the other bones included are tegmen, posterior canal erosion, sigmoid sinus space, fallopian canal lesions, of which were 100% correlated on CT as well as in surgery. Discussion. Radiological investigation sometimes become necessary to access the pathologic material kept in incorporated children or in whom visualization of tympanic membrane difficult. It becomes imminent to investigate radiologically in patients with intracranial complications. In present study, all such patients were subjected to CT scan of temporal bones. CT imaging is an accurate method of depicting the extent and nature of disease in CSOM. The appearance of abnormal soft tissue opacity associated with bone erosion is highly suggestive of cholesteatoma. Absence of erosion mostly excludes the cholesteatoma. Routine preoperative CT scan was helpful in determining the anatomy of middle ear and mastoid, and it accurately predicts the extent of disease process in sinus, tympani, and facial regions. According to discussion, we have seen the cholesteatoma, pneumotensine, mastoid, fallopian canal dehiscence, fistula in semicircular canal, and bony erosions, all were 100% correlated on CT as well as surgery, except for cholesteatoma, in which 46 cases of cholesteatoma were identified CT and 4 cases conferred only on surgery, but not on CT because of the soft tissue. Whereas in ossicular destruction, we have seen that out of 50 cases, 35 cases had ossicular destruction, in which only 30 cases were confirmed was correlated to the CT, whereas other 5 was not correlated on CT except on the confirmed on surgery. This could be the reasons of presence of cerebral granulation tissue or any other soft tissue, and sometimes it's difficult to identify incurs and stapes on CT. Conclusion: the computerized tomography scan helps in assessing the type of lesion, location, extent of the disease, ossicular displacement of erosion, any bony erosions, fallopian canal dehiscence, semicircular canal fistulas, is assessing any anatomical variations like low-lying tegmen, or anterior placed sinus plate or abnormal facial nerve codes, and assessing any intracranial complications like temporal lobe and cerebellar abscess. In our study, in 46 cases out of 50 cases, the CT scan findings were correlating with the surgical findings. Only in 4 cases, there was a difference in the findings of CT scan with that of surgery. This is because the CT findings produced a false impression of resistance of tegment, lateral semicircular canal, or even the sinus plate. These erroneous impressions were due to computer averaging of the thin bony plate with adjacent soft tissue structures within the same slice. The large megaantrum can be and give a false impression of cholesteatoma. Overall, CT is much superior to plain radiography in the assessment of CSOM, both preoperative and postoperatively. Thus, routine CT imaging in all patients with CSOM assists in patient counseling, planning the surgical approach, and prepares the surgeon for difficult situations. Thank you, sir. These are my references, sir.
Doctor, you told that CT scan is helpful both pre-operatively and post-operatively. What is the role of CT scan post-operatively?
So, post-op, uh, can you please repeat the question again?
So you told that CT scan
Yes,
is helpful both pre-operatively and post-operatively. What is the role of CT scan post-mastectomy
So, if
in
any
the case of
complications,
cholesteatoma?
in case of cholesteatoma, to see any remnants, if the patient complains of it, comes to follow up, if he has any complications, if he has any discharges, and which is causing any complication intracranially, so we can the CT scan helps post-operatively also, sir.
Okay, thank you.
Thank you, sir. Very how
Dr. Divyanani, are you ready?
Yes, sir.
Please share your screen.
Sir, can I start?
Please make it full screen, please.
Full screen, please.
Yes, sir, full screen, sir.
No, we are not getting full screen.
Wait. So it is full screen on my screen, sir.
Now, right side bottom, you have to click. There is a cup-shaped icon. You click that.
So,
Just beside your zoom option.
I couldn't find it, sir.
Okay, Dr. Divyanani, we will come back to you at the end.
Okay, sir.
Dr. Sahasra, are you ready?
Yes, sir. I'm ready.
Yeah, share your screen.
Shall I start, sir?
Sir, serial number 5, Dr. Sahasra is presenting, sir. Please make a note
Okay,
of it.
sir. Okay, sir. Okay.
Yeah, Dr. Sahasra, please go ahead.
Okay, sir. Good morning, sir. The title of my presentation is Prospective Clinicopathological Study to Estimate Hearing Loss with Different Size and Site of Tympanic Membrane Perforation in Patients of Safe Chronic Suppurative Otitis Media. Introduction. CSM is one of the most common ear disease in developing countries. It is defined as a persistent disease, insidious in onset, often capable of causing severe destruction of middle ear structure with irreversible sequelae, which is clinically manifested with deafness and discharge for more than 3 months. CSM can lead to conductive hearing loss up to 60 decibels and more. Tympanic membrane comprises 3 layers. outer epithelium, middle fibrous, and inner mucosal layer. Intact tympanic membrane protects middle ear cleft from infections and shields round window and the conduction of the sound. In TM perforation, it represents a loss of intactness, establishing a communication between middle and external ear. In tympanic membrane perforation, pressure gradient between inner and outer surface of tympanic membrane virtually becomes insignificant. Thus, transmission of the sound wave to the ossicular chain is hampered. Posterior inferior perforation abolishes the sound protection effect of round window and hence will cause more hearing loss than perforation in other quadrants. The hearing loss will be proportional to the size of perforation. The larger the size of perforation, greater the amount of the hearing loss. Aims and objectives: to study the demography of safe CSOM, to determine the etiologies of tympanic membrane perforation for safe CSOM, to study symptomatology of tympanic membrane perforation, audiometric evaluation of patients with different size and site of perforation, to determine the frequency maximally involved with size and site of perforation. Materials and method. Study was done in otorhinolaryngology department at our institution based on our inclusion and exclusion criteria. Sample size is 50. This is a prospective observational study. Statistical analysis was done using Pearson's chi-square test. Inclusion criteria: patient of both gender with ages ranging from 16 to 50 years, patient with dry perforation, that is history of no ear discharge for past 3 weeks, patient with good cochlear reserve. Exclusion criteria: age up to 16 years and above 50 years, patients with deformity of external auditory canal, known eustachian tube dysfunction, patient with previous failed myringoplasty, patient with active discharge, patient with cholesteatoma, retraction pockets or associated mastoiditis, patients with ear malignancy and other debilitating diseases. Methods: all patients were assessed by detailed history and clinical examination. Site and size of perforation will be recorded. Hearing assessment will initially performed clinical by tuning fork test and followed by the pure tone audiometry. The tympanic membrane is divided into 4 segments: anterior superior, anterior inferior, and posterior inferior. The size of the perforation in my study was measured by taking a thin and transparent plastic paper which was marked with the 1 mm square graph, and it is cut into the oval shape of the tympanic membrane, and then it is sterilized by keeping in Sidex, and then it is placed over the tympanic membrane perforation, and it is absorbed by the otoscope with 3 into magnification. The total effective surface area of the tympanic membrane is 55 mm square, and the size of perforation were characterized as 1 to 14 mm square, which is single quadrant involvement, that is small perforation. 15 to 27 mm square, that is 2 quadrant involvement, it is a medium size perforation. 28 to 41 mm square, more than 2 quadrants involved, that is large perforation. 40 to 55 mm square, where all 4 quadrants are involved, that is subtotal perforation. Coming to the results, the age distribution: maximum patients were in the age group of 20 to 29 years, followed by 30 to 39 years of age group. Minimum patients were in the age group of 50 to 59 years. Mean age of the patient in the study was 28 years. Gender distribution: in my study population, 60% are female and the 40% are male. Etiological factors: infection was the most common etiological factor, followed by the traumatic and then idiopathic. Duration of the disease: maximum number of patients had duration of disease between 6 months to 1 year. Presenting symptoms: the major symptom of the CSOM is otorrhea, but as per my inclusion criteria, as we have taken the dry ears, now here the most common presentation is the hearing loss, then tinnitus, and then otalgia. Comparison of mean range of hearing loss in identical size of anterior inferior and posterior inferior quadrant perforation. The greater mean range of hearing loss is reported in posterior inferior quadrant perforation than the anterior inferior quadrant perforation. Here is the graph showing association between size of tympanic membrane perforation and degree of hearing loss. The subtotal perforation has reported the severe form of hearing loss, whereas medium and large size perforations, maximum member of patients have shown the moderate type of hearing loss, and in the small size of perforation, maximum numbers are reported with mild conductive hearing loss. The larger the size of the tympanic membrane perforation, the higher the degree of hearing loss. This was the statistically significant. This is the graph showing association between site of TM perforation and severity of hearing loss. Posterior perforation has more hearing loss than the anterior perforation of the same size. Discussion. Ideal et al. Noted that high proportion of study participants were within the younger age group of 10 to 13 years, which is agreement to our study. Similar findings were reported by Sood et al., in which 79% of the study were less than 40 years of age. Singh et al. Observed that hearing loss was slightly greater in posterior perforation than the anterior perforation. Maharajan et al. And Nepal et al. Showed statistically significant relationship between site of perforation and hearing loss. Ribeiro et al. Found no significant relationship between the size of perforation and hearing loss. Study done by Pano et al. Showed that hearing loss was more in posterior quadrant perforation than the anterior perforation. Conclusion. Young and middle-aged population of low socioeconomic class are the most common sufferers of the chronic suppurative otitis media. Hearing losses and PTA in dry TM perforations range from 16 to 46 decibels, and that is roughly 2/3 of the cases have mild conductive hearing loss. Average hearing loss have been observed to be greater at lower frequencies than at the higher frequencies. Hearing loss increases with increase in the size of tympanic membrane perforation. Site of perforation is also an important factor, as posterior quadrant pars tensa perforations have greater hearing loss than the anterior quadrant perforations. These are my references. Thank you.
So what is acoustic coupling and oscillator coupling?
Sorry, sir, I didn't get you.
What is acoustic coupling and oscillator coupling?
Oscillator coupling is the oscillator chain which transmits the sound within the oval window and the round window. Acoustic and stepedial reflection.
Okay, thank you.
Thank you, sir.
Dr. Arshia,
Yes, sir.
madam, are you ready?
Yes, sir.
Please share your screen, madam.
So, are you able to see, sir?
Yeah. You
Okay.
can continue.
Yeah, my name is Dr. Arshia Jepin, and today I am going to present a case series of pediatric subglottic stenosis, highlighting the clinical presentation, management, and the outcomes. So that subglottic stenosis is defined as a narrowing of the upper airway extending from just below the vocal folds to the lower border of the cricoid cartilage. It can either be congenital or acquired. In congenital, it is present since birth as the recanalization process fails to occur, and acquired, it develops after the birth, and it is the more prevalent of the two. And the primary cause for the acquired subglottic stenosis being iatrogenic. The several predisposing causes in the pediatric age group are the low birth weight, low gestational age, longer duration of intubation, traumatic intubation, multiple intubation, as well as using a larger than required size of the intubation. Among all these, the most common cause of laryngotracheal stenosis is prolonged endotracheal intubation, where we have seen that about 90% of the cases having a history of prolonged intubation lasting longer than 12 to 24 hours. And based upon the severity of the obstruction of the airway, it can be graded into either 1, 2, 3, and 4 as given by the Mayer-Cotton grading system. And the evaluation of the pediatric subglottic stenosis involves a thorough history and clinical examination as well as various investigations. The clinical presentation can be in the form of shortness of breath, stridor, respiratory distress, hoarseness of voice, persistent cough, failure to thrive, or cyanosis. Investigations can be done in the form of OPD basis with the help of awake flexible fiber optic laryngoscopy or conventional direct laryngoscopy and rigid laryngobronchoscopy. CT and MRI also have got a limited role in the diagnosis of subglottic stenosis. Coming to the management options, it can include either conservative approach like observation and using of corticosteroids, or going for various surgical intervention for both acquired and congenital types in the form of either endoscopic repair using coblation, microdebrider, carbon dioxide laser, balloon dilations are by using open procedures like LTR, laryngotracheal reconstruction and cricotracheal resections. At any point of time, tracheostomy plays a very crucial role in securing a functional airway. My first case is an 8-year-old girl presented to us with noisy breathing, respiratory distress, and breathlessness on exertion since the past 2 months. She had a past history of Ray's syndrome 6 months ago, for which she was on ventilatory support for about 7 days. She also underwent one episode of gum elastic bougie dilatation at an outside hospital with limited success. So a flexible laryngoscopy was done in OP basis, where we have seen that the child had an subglottic stenosis, and it was about grade 3. So this was how the subglottic stenosis was. So we took the child to the theater and did a microlaryngobronchoscopy, and we had planned to take her for the balloon dilatation. So balloon dilatation is a minimally invasive procedure in which a balloon catheter is introduced into the narrowed airway and is inflated to widen the stenotic area. Once the balloon reaches the desired pressure, it is held there in the place briefly and then deflated and removed. Normally, in subglottic stenosis, we use a pressure ranging from about 3 to 12 atmospheres, each dilation lasting for about 30 to 120 seconds, depending upon the severity and the age of the patient. So after about 1 minute or so, 1.5 minutes or so, we have deflated the tube and removed it. So post-op follow-up flexible laryngoscopy showed that there was almost normal laryngeal inlet without any injury to the mucosa. So this was the pre-op presentation, and this was how post-op the laryngeal movement was. So my second case. My second case is about a 2 months female baby who was having a respiratory distress since birth, which was aggravated since the past 1 week. She was a late preterm with birth weight of about 2.6 kilograms. She cried immediately at birth, but at around 6 hours of birth, she developed severe respiratory distress, for which she was ventilated. At around 7 days of life, she developed severe stridor, for which she was evaluated, and a diagnosis of laryngomalacia with subglottic stenosis was established. She underwent supraglottic stenosis repair along with subglottic dilatation at an outside hospital. She recovered for some time, but subsequently the baby developed sepsis requiring prolonged ventilation and PICU stay. When she came to us, we did a flexible laryngoscopy, and this was the presentation. We can see that she had a grade 3 subglottic stenosis. A regional laryngobronchoscopy was done, and grade 3 was done in an OT setup, and we could see that the laryngomalacia still persisted with foreshortened AE folds, and then a grade 3 subglottic stenosis was seen. The balloon dilatation was carried out on this child, and then after the balloon dilatation, we could see that posterior part of the cricoid cartilage appeared to be exposed. So we immediately went for an open procedure. A tracheostomy was done on this child, and a cuffed cortex Bivona tracheostomy tube of size 3.0 was placed in situ, as well as a Africa stent was also placed. So this was the Africa stent. It was placed within the lumen, and the posterior end of the stent was secured to the outside skin via the tracheostomy stoma. For the laryngomalacia, the AE fold release was also done by coblation. Subsequent micro laryngobronchoscopies were done every week, and after about 45 days, the stent was removed. The subglottic mucalization was found to be satisfactory, and the child was decannulated after 2 months. So post-op, after 2 months, this was how the child was. There was marked improvement in the laryngeal lumen. There was patent laryngeal lumen. Coming to my third case, it was a 28-year-old baby boy who presented with respiratory distress and stridor since birth. He was
50
ventilated
seconds
and
left.
I was later weaned into CPAP. Flexible fiber optical laryngoscopy was done and grade 3 subglottic stenosis was established. We have again done balloon dilatation on this child. And post-operatively, we could see that there was patent laryngeal lumen. So conclusion, being the third most common congenital anomaly of the larynx, subglottic stenosis requires early recognition supported by imaging and endoscopic evaluation, and so that management options ranging from endoscopic dilatation to surgical reconstruction depending upon the severity. So these are my references. Thank you.
Does any of your case require an open procedure like LTR or CTR?
Yes, sir. I have not presented them in this, sir, because we have done just recently, about 1 month ago, sir. There was a complete stenosis of the grade 4 stenosis was there. We have gone for partial cricotracheal resection, sir. But the outcome is awaited, so I didn't include in this series.
Okay, thank you.
Good presentation, madam. Dr.
Thank you.
Shilpa, are you ready?
Yes, sir, I'm ready.
Yeah, please share your screen.
Yes.
Make it full screen. Yeah.
Yes, sir.
Now you can start.
Good morning, everyone. I am Dr. Shilpa. I'm presenting a comparative study between posterior tympanotomy and Varia technique for cochlear implantation. Cochlear implants are true bionic organs. Are true bionic organs. Cochlear implants, like human hair cells, converts mechanical sound energy to electrical impulses. Cochlear implants have evolved from a single-channel electrode to a complex multi-channel electrode. Different surgical approaches have been adopted for cochlear implantation, with cortical mastodectomy and posterior tympanotomy being the most common. And non-mastodectomy techniques like transcanal approach and other modifications like suprameatal and pericanal approaches for electrode insertions are also there. The aim of my study was to compare between posterior tympanotomy and Varia technique for cochlear implantation. The two objectives of my study are to compare the surgical complications of both the techniques and to evaluate the advantages and disadvantages associated with both the surgical approaches. The methodology. My study design is a hospital-based prospective comparative study. The study period is for 18 months. Sample size is 100. The sampling method I used is simple randomization. My inclusion criteria are children aged less than 5 years, bilateral profound sensorineural hearing loss, no appreciable benefit with hearing aid, no medical or anatomical contraindications, motivated patients for cochlear implant surgery, and willingness to follow up. My exclusion criteria are age below 6 months and above 5 years, children with cochlear nerve aplasia, central auditory lesions, and non-pneumatized master, child with active ear disease, and mentally challenged children. Methods of collecting data. Preoperative workup was done for every child with audiological investigations, routine blood investigations, pediatrician, psychologist, ophthalmologist, and cardiologist opinions. The pneumococcal polysaccharide and meningococcal vaccination was done for both the groups at least 3 weeks to 4 weeks prior to the surgeries. After that, both the populations were divided by random allocations into Group A and Group B. Group A underwent surgery by posterior tympanotomy and Group B by Varia technique. According to the study criteria of Cohen and Hoffman, the complications were classified into major and minor complications. The major complications are electrode insertion problems, tympanic membrane perforation or retractions, flap dehiscence, cholesteatoma formation, chronic ear discharge due to recurrent otitis externa. The minor complications were transient facial nerve palsy, posterior meatal wall injury, chorda tympani nerve injury, skin flap infections, and EAC granulations. Coming to my case 1, this was a 2-year-old female baby which was operated via posterior tympanotomy approach. Here you can see the facial recess and the round window which is seen through the facial recess, and the electrodes are placed through the round window. Postoperative canvas view X-ray which showed that the implant was still in situ. This child did not develop any complications. 2-year-old male child which was operated again by posterior tympanotomy approach. Round window insertion of the electrode can be seen through the facial recess, and wound gaping was noted on postoperative day 7, for which we did regular dressings and it healed. 2-year-old child operated by Varia technique. The next case, here the child developed immediate post-op facial nerve palsy of grade 3 which recovered after steroids. Case number 4, 2-year-old child who was operated by Varia technique. Here you can see the tunnel entry or the suprameatal well at 11 o'clock and exit medially in the middle ear at 9 o'clock position. This child developed right ear granulation tissue post-op, which had to be curated, and local and IV antibiotics was given, after which the child, symptoms subsided. Coming to the observation and results of my study, the baseline characteristics in both the groups were comparable. The minor complications, we could see that based on the Fisher-Exat text, statistical analysis was done for both the groups, and we found that posterior meatal wall injury and EAC granulations were found to be more in Varia techniques compared to that of the posterior tympanotomy technique. In major complications, again, tympanic membrane perforation or retraction and ear discharge due to chronic otitis externa were found to be statistically more in Varia techniques compared to that of the posterior tympanotomy techniques. When we compared both the major and minor complications of the groups, we found that Varia technique had comparatively more complications compared to that of the posterior tympanotomy techniques. The CAP scores, that is the categories of auditory performance score in both the groups, were comparable. There were no difference. Coming to the discussion, first articles describing surgical complications related to cochlear implant was published in 1991 by Cohen and Hoffman. That is the same principle which I have also taken in my study, based on which I have divided into minor and major. Here we can see that transient facial nerve palsy can occur in both Varia as well as in posterior tympanotomy. But in posterior tympanotomy approach, damage to the facial nerve can be minimized by correctly identifying the landmarks using facial nerve monitoring and studying the precise course of the facial nerve. Posterior meatal wall injury happens in Varia technique because surgeons inadvertently traumatize the posterior wall of the EAC while creating the surgical access to reach the cochlea. This can happen during the initial stages of the procedure when preparing the entry point to the middle ear. Chorda tympani nerve injury and skin flap infections were almost the same in both the techniques. EAC granulations are more in transcanal technique because there is an endoral incision and mobilization of the tympanomeatal flap, which has higher chances of tympanic membrane perforation, disturbed angulation of the tympanic membrane, and postoperative granulations in the external auditory canal. Coming to major complications, electrode insertion problems happens in Varia technique because electrode handling is minimal in posterior tympanotomy, while in transcanal, the electrode arrays passes to 3 bends from the transcanal well into the tunnel at its entry, exit from the tunnel, and then through the cochleostomy. Cholesteatoma and severe retractions of past ends are again more in Varia technique because of the tympanomeatal flap elevation. The advantages of transcanal are better visualization of round window, avoidance of drilling of mastoid, and easy learning curve for the surgeons. While disadvantages are entry of the electrode arrays at an angle to the basal turn of cochlea, handling of the electrode as it stops in the tunnel needs to be pushed, which may lead to kinking, and complications are high due to involvement of the ear canal. Coming to my conclusions, surgeons performing posterior tympanotomy approach should be aware of the course of the facial nerve and should be able to modify the surgical technique as such. The meticulous surgical technique and advances in imaging technologies have minimized these risks and leading to overall low complication rates in the experienced hands. Both the techniques have its advantages and disadvantages and should be performed after careful consideration. These are my references. Thank you.
Doctor, have you used any CT criteria for choosing what type of procedure are you going to do?
Sir, actually, in my exclusion criteria, I have excluded those patients who did not have pneumatized mastoid cavity, sir. So that both the confounding factors are the same. Because Varia techniques is more preferred in those patients who have non-pneumatized mastoid cavity. So I have chosen only those patients or those children who had well pneumatized mastoid cavity.
In how many cases you have done a round window insertion in posterior tympanotomy, and how many cases you have done round window insertion in Varia technique?
In Varia technique, about 15 cases, we could do round window insertion, sir. In posterior tympanotomy, all the cases were round window insertion.
Okay. Okay, thank you.
Thank you, sir.
Yeah, that's a good presentation, Dr. Shilpa.
Thank you, sir.
Dr. B. Ramani Manasa.
Yes, sir. Good morning, sir.
Yeah, share your screen.
Yes, sir.
We are not getting your screen. Are you sharing? Dr. Ramani Manasa? Dr. Ramani Manasa, once stop
Sir,
sharing
good
your
morning,
screen.
sir. Okay, sir.
We are not getting your presentation.
Should I start, sir? Should I share the screen right now?
Yeah, share. No, we are not getting your PPT.
Can you give me 10 seconds, sir?
Yeah, we will be going ahead with the next presenter. Okay.
I
After that,
think
you
it
can
is
present.
sharing, sir.
No, we are not getting it.
Now, sir?
Yeah, now make it full screen.
Okay, sir. Now is it visible, sir?
You can start now.
Okay. Good morning, sir. I'm Dr. Manasa. Today, my topic is post-COVID ENT manifestations other than mucormycosis. COVID-19 has a diversity of presenting features such as classically fever, cough, fatigue, dyspnea, and headache, and non-classical symptoms such as smell and taste abnormalities. COVID-19 presented mainly with the lower respiratory tract-related symptoms like fever, cough, dyspnea, and chest tightness that could progress rapidly to acute respiratory distress syndrome. WHO case definition of post-COVID-19 condition. It occurs in individuals with a history of probable or confirmed SARS-CoV infection, usually 3 months from the onset of COVID-19 with symptoms that last for at least 2 months and cannot be explained by any other alternate diagnosis. Long COVID-19 has a plethora of ENT symptoms such as tinnitus, sensorineural hearing loss, vertigo, nasal congestion, sinonasal discomfort, hyposmia or anosmia, dysgeusia, sore throat, dry cough, facial palsy, and hoarseness of voice. People who are not vaccinated against COVID-19 are at a higher risk of developing post-COVID-19. Mucor is a well-known post-COVID manifestations other than malaise, fatigue, fever, difficulty breathing, cough, neuropathy, depression, and so on. Aims and objectives of my study are to study post-COVID non-mucor ENT problems in the patients of different age groups coming to outpatient department to determine the proportion of post-COVID ENT complications other than mucormycosis to assess medical comorbidities in such patients. Materials and methods used are my study design is a prospective observational study conducted in the outpatient ENT department. Study period was about 18 months and sample size is 100 patients. Inclusion criteria, I have taken post-COVID patients recovered from COVID-19, age 18 to 17 years, and exclusion criteria was previous history of tinnitus, anosmia, sensorineural hearing loss, facial palsy before COVID. I have taken first 100 patients who fulfilled the inclusion criteria. Informed written consent was taken for inclusion in the study. Post-COVID-19 status of the patient, which was confirmed through RT-PCR, nasopharyngeal, oropharyngeal swab, or rapid antigen test were noted and proven negative now through rapid antigen test. They were followed for 30 days, 60 days, and 19 days. Age, sex, resident, vaccination status, comorbidities, addictions, post-COVID ENT manifestations were recorded. General, local, and systemic examination done. Functional tests were done, and tabulation of analysis was of data was done. Functional tests included tuning fork test, pure-tone audiometry, nasal smell test using pocket smell test using taste strips of 4 flavors: sweet, sour, salty, and bitter. Nasal diagnostic nasal endoscopy, ear examination under microscope, video laryngoscopy was done. Case 1 was a 27-year-old male who had chief complaints of bilateral nasal discharge since 6 months. He had a history of COVID-19 6 months back, which was confirmed by RT-PCR. Now his RAT is negative. Vaccination, he received 2 doses of Covishield, and he's a social drinker since four years. Anti-rhinoscopy showed mucoid discharge present in bilateral nasal cavities. Diagnostic nasal endoscopy showed mucoid discharge in bilateral middle meatus. CTPNA showed bilateral maxillary sinusitis. Provisional diagnosis post-COVID chronic rhinosinusitis. Second case was a 57-year-old female who had bilateral hearing loss since 10 months. She had history of COVID-19 10 months back, confirmed by RT-PCR. Now she's RAT negative. She received 2 doses of Covishield. Functional test, bilateral ear release was positive, Weber's to the right, and absolute bone connection, bilateral ears less than the examiner. Bilateral ear endoscopy under microscope showed the bilateral EAC normal, and left side grade 1 pars sensor retraction. My provisional diagnosis is post-COVID bilateral profound sensory neural hearing loss. Case 3 is a 36-year-old male who had loss of smell since 7 months, past history COVID-19 7 months back. He received 2 doses of vaccination, Covishield. He's a BD smoker since 10 years. Pocket smell test, he was not able to perceive 4 smells. Bilateral diagnostic nasal endoscopy was normal. CTPNS is also normal. Provisional diagnosis is post-COVID anosmia. Next is 28-year-old female who had loss of taste since 6 months. She had a history of COVID-19 6 months back. She's a diabetic since 4 years on regular medication. She received 2 doses of Covishield. Taste card test, not able to test any of the 4 flavors. Indirect laryngoscopy and video laryngoscopy was normal. Provisional diagnosis post-COVID dysgeusia. Next case is a 30-year-old male who had difficulty swallowing solids more than liquids since 6 months. He had past history of COVID-19 6 months back, confirmed by RT-PCR. Now RAT is negative. He received 2 doses of Covishield. He's a social drinker since 10 years. Indirect laryngoscopy, video laryngoscopy, and barium swallow were normal. My provisional diagnosis is post-COVID neurological dysphagia. Observation, maximum patients were in the range of 51 to 60 years, followed by 31 to 40 years, and male to female ratio is 3:2. Most of them were vaccinated, 94%, and most of them had alcoholic and smoking addictions. Most common comorbidity was hypertension, followed by diabetes mellitus in the range of 22% and 17%. Other comorbidities were chronic liver disease, coronary artery disease, and asthma. Frequency distribution of symptoms, most of them had dyspnea. Dyspnea was in 22% of the patient, followed by rhinitis, tinnitus, and dry cough in 19%, 18%, and 18% patients. After follow-up, many of them normalized, about 66%, and hyposmia and anosmia were in 29 and 5% cases. Discussion, clinical presentation of SARS-CoV infection is now classified into mild, moderate, severe. Mild had no evidence of viral pneumonia or hypoxia. Moderate have clinical signs of mild pneumonia, and severe manifest with severe pneumonia. According to Sharma et al. Systemic review, he revealed the broad spectrum of ear symptoms after recovery of COVID-19 was hearing loss, tinnitus, vertigo, facial palsy, earache, and oral fullness. Nasal symptoms and associated chemosensory deficit from Sharma et al.'s data revealed parosmia, hyposmia, anosmia, dysgeusia, nasal discharge, nasal blockage, and sinonasal pain. Throat and laryngeal symptoms, according to Sharma et al., was hoarseness, sore throat, dry throat, dyspnea, and cough. Conclusion, my results showed mean age was 43 years and majority belonging to urban background. Sex ratio was 3:2 and majority were vaccinated. Smoking and alcohol were noted in most of the patients, and most of them were diabetes and hypertension. ENT manifestations in decreasing order, they were mainly, first was anosmia and hyposmia, and other complaints in decreasing order were dyspnea, rhinitis, tinnitus, dry cough, sore throat, and change of voice. My study is comparable to other studies by Dr. Swapnil, Dr. Graham, Jennifer, Dr. Rizzo, Dr. Goretz, and Augustine et al. These are my references. Thank you.
Thank you. Yeah, we can move on to next.
Okay. Dr. Anusha,
Sir?
are you ready?
Yes, sir.
Share your screen.
Can you hear me, sir?
Yeah, it is fine.
Okay, sir. I'm sharing, sir. Just wait a minute. Can I
You can
start,
start.
sir?
Yeah.
Good morning, everyone. I'm Dr. Anusha. I'm going to present a case series of importance of septal surgery in correcting external nasal deformities. Introduction. The nasal septum plays a pivotal role in both the aesthetics and functionality of the nose. Septal surgery is performed to resolve breathing problems, but it often becomes pivotal to correct external nasal deviation, representing a central step in rhinoplasty surgery. Even in the patients with no functional problems, septal surgery may represent the best solution for obtaining a proper realignment of the external nasal pyramid. The cosmetic complaints related to the nasal septum result from twisted cartilaginous nasal dorsum, deflection of the caudal septum, prominent anterior septal angle, a saddle nose deformity, a cartilaginous dorsal hump, and a crooked nose. The aim of our study is to discuss the close relationship between the nasal septum and the aesthetics of the nose, and how a graduated surgical approach for the correction of the septal deviation could affect
Dr.
the
Anusha,
external.
Dr. Anusha, once. Start your video. We are not getting your video.
Sir, is it fine now?
Yeah, okay, start.
The aim of our study is to discuss the close relationship between the nasal septum and the aesthetics of the nose, and how a graduated surgical approach for the correction of the septal deviations could affect the external deviated nose. To provide a comprehensive overview of the surgical techniques employed, patient outcomes, complications, and overall satisfaction. The materials and methods. A retrospective case series analysis was conducted in all the patients who underwent a correction of the external nasal deformities with concurrent septal surgery in our institution over a period of 1 year with a sample size of 8. Inclusion criteria. The study included the patients with the external nasal deformities related to the nasal septum who underwent rhinoplasty with concurrent septal surgery. Patients within the age group of 16 to 30 years, patients who are in overall good health condition and without any significant comorbidities, patients with the realistic expectations regarding the aesthetic outcomes. Exclusion criteria was all the revision cases and the patients with significant nasal pathologies like malignancy, severe chronic rhinosinusitis, active infections are excluded from the study. Patients with the serious systemic conditions and the psychiatric illness are excluded from the study. The methodology. A detailed preoperative assessment was done, including a detailed patient history and previous history of surgeries. Nasal examination along with the functional assessment was done. CT 3D facial bones and PNS was done to assess the septal anatomy of the septum and the nasal bones. Informed consent and photographic documentation for evaluation was taken from all the patients. The photographic documentation was taken from different profiles of patient. A rhinoplasty outcome evaluation questionnaire, which composed of 6 questions, was used to access the aesthetic result after the surgery. Each question is given a score of 0 to 4. The ROE scores range from 0 to 24, that is 0 to 100%. Patients with scores more than 12, that is 50%, are considered satisfied. Surgical approaches and techniques. The approach and the surgical technique, whether open or the closed rhinoplasty, are based on patient's anatomy, location of deformity, goals, and the surgeon's preference and experience. Out of 8 patients, 4 were treated with endonasal approach and 4 were treated with open approach. A case of twisted dorsal septum was treated by separating the septum and the upper lateral cartilage on the convex side. The weakening of the cartilage was done by scoring, and the carving is done, and the septum is realigned. Here we can see the preoperative and postoperative picture after the correction. A case of the prominent septal angle is treated by resection of the cartilage of the anterior septal angle and the caudal edge along with overlying mucosa.
Dorsal trimming of the excess septal and the upper lateral cartilages causing the hump is done in the patient with cartilaginous nasal hump. A patient with the deflected caudal septum causing the nasal obstruction is treated by separating the deflected caudal septum from the mucopericordial flaps on both the sides. The septum is reinserted back and the suturing was done. Here we can see how a correction was done. The correction of a crooked nose was done by initially giving a columellar and marginal incision. The dorsal nasal flaps are elevated. The septum is separated from the upper and lower lateral cartilages. The subradical excision of the septum was done. The cartilage was diced and a part of cartilage was used as spreader graft. These are the preoperative and postoperative pictures of the patients with a crooked nose before and after correction. A case of saddle nose deformity was corrected with the augmentation rhinoplasty. Columellar and marginal incision was given. Dorsal nasal flaps were elevated. The septal cartilage was harvested, and initially a conchal cartilage was also harvested. Augmentation was done using the septal and the conchal cartilage. This is the preoperative and postoperative pictures showing how the correction saddled nose was corrected along with the bifid tip. Postoperative infections, anterior nasal packing was done. The cast was applied for a duration of 1 week and checked for any signs of excessive swelling, discoloration, or drainage around the cast. Observation, regular follow-ups at 1 week, 1 month, 3 months, and 6 months was done. Aesthetic outcomes and patient satisfaction was evaluated. Results show that all the patients are satisfied with the ROI scores more than 50%. There were minor complications such as post-operative edema, minor bleeding, synecdoche formation, and temporary nasal congestion. There were no significant long-term complications. Out of 8 patients, 5 patients were females and 3 patients were males. Discussion. Successful correction of a deviated nose is accomplished when all the anatomical constituents involved in the defect are adequately identified and surgically straightened. However, in the rhinoplasty algorithm, septum abnormalities and septal surgery are often underestimated and inaccurately labeled as complementary to tip surgery or nasal wall surgery. Therefore, the septum deserves attention not only for the functional but also for the aesthetic surgery. Conclusion. Value of septal surgery in achieving the balance between nasal form and function with high patient satisfaction and minimum complications was the aim of our case series. Even in the absence of functional problems, correction of minor and major septal deviations can determine realignment of external nose. The endonasal or the open approach should be determined by detailed preoperative evaluation. Future prospective studies with larger sampler sizes and longer follow-up periods are warranted to further validate these findings. These are my references, sir. Thank you.
So will you do osteotomies for these cases when you
Yes, sir.
correct a crooked?
Yes, sir. When required, we have even done the osteotomies. For a case of crooked noses, we have done lateral osteotomies as well as lower lateral osteotomies we have done, sir.
Okay, thank you.
Thank you, sir.
That's a good presentation, Dr. Anusha.
Thank you, sir.
Next, Dr. Lochana Prasad.
Can I share my screen, sir?
Yeah.
So can I start?
Really great. Is it your first slide?
One. Can I start,
Now
sir?
you can. Yeah, now you can start.
Good morning, sir. I'm Dr. Lochana Prasad Reddy, and my case series is a cross-sectional study on impact of coca bullosa in chronic rhinosinusitis. Chronic rhinosinusitis is a group of disorders characterized by inflammation of nose and paranasal sinuses of at least 12 consecutive weeks duration. Conca bullosa is the pneumatization of middle turbinate, which is a common variation of sinonasal anatomy.
Concha bullosa intruding into the middle meatus may fill the space between septum and lateral wall, impinging on the infundibulum and maxillary sinus ostium, creating areas of mucosal contact and alters the normal airflow, thus producing negative influence on paranasal sinus ventilation and on mucociliary clearance in the osteomeatal complex. Thus, it can make the relevant sinuses prone to infection. Therefore, there is a need to study the relationship between concha bullosa and chronic rhinosinusitis. Concha bullosa represents the presence of air cells inside the middle turbinate. The concha bullosa is a common anatomical variant of sinonasal tract in general population. It may be unilateral or bilateral. Pneumatization of the middle turbinate is an extension of normal pneumatization process of the ethmoidal air cells. Based on the location, Bolger et al. Classified the pneumatization of turbinates as lamellar concha bullosa, that is pneumatization of the vertical lamella of the turbinate only, bulbous concha bullosa, that is pneumatization of the bulbous part, and extensive concha bullosa, where pneumatization of the entire middle turbinate is present. In this picture, we can see the first being bulbous concha bullosa, the second showing extensive, that is the entire, and the third showing a lamellar type of concha bullosa. The aim for my study was to study the impact of concha bullosa in chronic rhinosinusitis, and my objectives were to find out the percentage and role of concha bullosa in patients of chronic rhinosinusitis, to screen the patients of chronic rhinosinusitis for concha bullosa, and to do nasal endoscopy and CT scan of the screened patients. Coming to my materials and methods, this was a cross-sectional study design with a sample size of 100 patients. For my inclusion criteria, patients of chronic rhinosinusitis satisfying the clinical criteria by the Task Force on Rhinosinusitis were included, patients above 10 years of age, and patients who are willing to undergo CT scan of nose and paranasal sinuses and diagnostic nasal endoscopy. My exclusion criteria were patients with history of previous nasal surgery, patients with acute rhinosinusitis, and patients with tumors of nose and paranasal sinuses were excluded. Coming to my methodology, the first 100 patients who fulfilled the inclusion criteria were selected for the study. Details regarding the proposed study were explained to the patient and attenders, and written and informed consent was taken for inclusion in this study. Particulars like age, sex, residence, presenting complaints, duration of illness, relevant history, past history, treatment history, clinical signs and symptoms were recorded. Using 4% topical xylocaine as anesthesia and decongestion using topical adrenaline, diagnostic nasal endoscopy was done to study the presence of concha bullosa in the selected patients. These patients all underwent a CT scan, which enabled us to study the presence of concha bullosa radiologically as well. An association between concha bullosa and occurrence of chronic sinusitis was made through this study. Coming to my observations and results, the incidence of concha bullosa in my study was 62%, that is 62 out of the 100 patients who had chronic rhinosinusitis. For the distribution of unilateral and bilateral concha bullosa, 32 patients were seen to have unilateral, whereas 30 patients had bilateral, showing a slight predominance of unilateral concha bullosa in my study. The distribution of concha bullosa according to type, a total of 92 cases of concha bullosa, that is right and left, in the 62 patients were seen. Extensive was seen in 39 cases, bulbous was seen in 33 cases, and lamellar was seen in 20 cases. In our study, the extensive type of concha bullosa was the most predominant in patients of chronic rhinosinusitis. The association between concha bullosa and chronic maxillary sinusitis. Out of the 72 patients who present to us with chronic maxillary sinusitis, concha bullosa was present in 54 of them, whereas it was absent only in 18 patients. We have taken a chi-square test for statistical analysis, which showed a significant p-value at less than 0.05. Hence, there was a very significant association between the presence of concha bullosa and the occurrence of maxillary sinusitis in our patients. Here we can see a patient with a left-sided concha bullosa with a bilateral maxillary sinusitis on CT scan. Association between concha bullosa and chronic frontal sinusitis. Out of the 56 patients who presented to us with frontal sinusitis, 32 patients presented with concha bullosa, whereas 24 patients did not have concha bullosa. With a chi-square statistic of 0.8, the p-value was not significant for this association between presence of concha bullosa and frontal sinusitis. Here we see an example of a patient who presented with left concha bullosa and frontal sinusitis. Association between concha bullosa and chronic ethmoid sinusitis. In our study, 52 patients presented with chronic ethmoid sinusitis, out of which 31 presented with concha bullosa and 21 had no concha bullosa. The p-value was 0.6, making it not significant at a p-value of 0.05. Here we can see a patient who presented with bilateral concha bullosa and bilateral ethmoid sinusitis. This is a diagnostic nasal endoscopy picture of the patient. Coming to association between concha bullosa and chronic sphenoid sinusitis, here a total of 3 patients with sphenoid sinusitis, only 1 out of which presented with concha bullosa. Here also the p-value was not significant at less than 0.05, and hence there was no significant association between the presence of concha bullosa and occurrence of sphenoid sinusitis. My discussion. Pneumatization of middle turbinate, which is referred to as concha bullosa, is one of the most common anatomical variations of the lateral wall of the nose. In our study, an attempt was made to study the percentage of chronic rhinosinusitis patients having concha bullosa and if this had any association with the occurrence of chronic rhinosinusitis. A total of 100 patients were selected for this study. After obtaining consent from all the patients, detailed history and clinical examination was done using a pre-tested questionnaire. The subjects who were selected underwent diagnostic nasal endoscopy and CT scan of paranasal sinuses to determine the sinuses involved and detect the presence of concha bullosa. The incidence of concha bullosa in our study was 62%. In our study, we found a statistically significant association between the presence of concha bullosa and occurrence of chronic maxillary sinusitis. The associations noted for chronic frontal, ethmoid, and sphenoid sinusitis were less significant. This can be attributed to concha bullosa intruding into the middle meatus, filling the space between the septum and lateral wall, impinging the maxillary sinus ostium, and decreasing the mucociliary clearance and ventilation, making the sinus prone to infection. My conclusion is that concha bullosa plays a major role in the development of chronic maxillary sinusitis. Thus, after confirming the presence of concha bullosa in a patient, the surgeon should keep in mind the possibility of development of chronic maxillary rhinosinusitis. This is my review of literature and references. Thank you.
Okay, thank you. You can move on, sir.
Next presenter, Dr. Pranavi.
Yes, sir. Can I share my
Share your
screen, sir?
Yeah.
Can I start, sir?
Yeah, you can start.
Good morning, sir. My case series is study of postoperative outcome and recurrence in endoscopic 7-layer closure of CSF rhinorrhea. CSF rhinorrhea results from a direct communication between the subarachnoid space and the paranasal sinuses. Any skull-based defect provides a route of development of pneumocephalus and secondary brain compression and also increases the risk of bacterial meningitis. The causes of CSF rhinorrhea can be spontaneous, traumatic, iatrogenic, or due to meningocele and meningoencephalocele. Few investigations like nasal endoscopy can be done. Beta trace protein of the fluid can be sent for evaluation to know if it is CSF or not. HRCT PNS with ultra fine cuts is most of the time diagnostic, but if the defect is not seen in the HRCT, we can go for MRI cysternography with any IV contrast. High resolution T2 weighted images can be obtained. Intrathecal fluorescent dye can be given in the intraoperative period, and the blue light filter can be applied over the endoscope to visualize the site of the defect and to see if there are multiple defects. CT temporal bone is done in patients in whom the HRCT and MRI are normal to rule out the causes of paradoxical rhinorrhea, that is CSF otorhinorrhea. The patients are first treated conservatively, and if the treatment fails, then the definitive management is surgery. The surgery can be done either via a transcranial approach or via endonasal endoscopic approach. The transcranial approach has a higher rates of recurrence. Its success rate is only 70%, and it has higher rates of complications like brain compression, hematomas, and seizures. Endoscopic multi-layered reconstruction provides a stronger barrier and reduces the chances of recurrence. The aim of the study is to describe the surgical technique of 7-layer CSF leak repair, along with lumbar drain placement and postoperative outcomes and propensity for recurrence. This is a prospective observational study conducted in the ENT outpatient department over a period of 18 months over 8 patients. Inclusion criteria includes all the patients who are diagnosed by nasal endoscopy and with CT or MRI cysternography, who are in the age group of 18 to 60, who had spontaneous or idiopathic and traumatic CSF rhinorrhea, Even the patients with underlying sinonasal pathologies like sinusitis were included. Exclusion criteria includes all the patients who had iatrogenic and congenital causes who were below the age of 16, below the age of 18 and above the age of 16, and patients who are non-consenting, and patients with uncontrolled systemic diseases and bleeding diathesis. This is the 7-layer technique we employed. First, a bipolar cautery was used, then a layer of thigh pad, followed by a layer of Surgicel, followed by fascial atta, then a layer of tissue glue, followed by a second layer of Surgicel and a second layer of tissue glue, finally with Merocil. Lumbar drain was placed intraoperatively and the CSF was drained for 5 days while constantly monitoring the patient's symptoms. Merocil pack was removed on the postoperative day 5. All the patients were followed up in the OPD with nasal endoscopy for up to 18 months. This is a patient who came to our OPD with right-sided rhinorrhea. The fluid was sent for beta trace proteins and and it came out to be positive for CSF. We got an MRI PNS done and it had a defect in the right cribriform plate, which had a defect of about 9/3 mm. The patient was posted for surgery. First, the thigh fat was harvested and it was placed in a solution of Metrogel until usage. Fascial atta graft was then harvested. Right partial middle turbinectomy was done to gain access to the cribriform area. Right anterior ethmoidectomy was done after performing the right middle meatal androstomy. Valsalva maneuver was given. We can see a meningocele, and after giving Valsalva, there was leakage of CSF from the area. Using bipolar cautery, the meningocele was fulgurated. Thigh fat was placed in an underlay fashion over which a layer of Surgicel was placed. Fascial atta graft was placed while hyperventilating the patient so as to reduce the intracranial pressure. Then good amount of tissue glue was applied all around the fascial atta graft to secure it in position. Then a layer of Surgicel was applied, and again a second layer of tissue glue was applied, and a small layer of Merocil was applied over the site of the defect. A separator was placed to separate the Merocil from the anterior nasal packing. Anterior nasal packing was done with Merocil and it was coated with betadine. This patient presented with a positive reservoir sign. In her, a diagnostic nasal endoscopy was done and the defect was found to be in the roof of the nasal cavity, that is in the fovea ethmoidalis. This patient presented with a defect in the left-sided sphenoid sinus. He also had a chronic sphenoid sinusitis. In this patient, posterior septectomy had to be done to gain access to the sphenoid sinus. Haddad flap was used along with the fascial atta graft. This patient had a traumatic CSF rhinorrhea. He had a fracture in the left cribriform area, which was measuring. He had a defect in the left cribriform area, which was measuring about 0.3 centimeters. The defect was identified in the diagnostic nasal endoscopy and the 7-layer CSF leak repair was done. This patient had a history of CSF leak repair 10 years ago. We can see the absence of uncinate and the widened maxillary sinus. The patient had a history of meningitis about a year ago, after which he had recurrence. In this patient, bath plug technique of the fat was employed and a thin layer of temporalis fascia graft was applied rather than the fascial atta graft. Observation: out of the 8 patients who had CSF rhinorrhea, most of them were spontaneous, and from the spontaneous, most of them were from the cribriform plate. In my study, 5 patients were females and 3 patients were males. The CSF rhinorrhea occurs due to defect in all the layers of bone, the dura, and the nasal mucosa. Over the follow-up of 18 months, no recurrence has been noted in any of the patients. After the lumbar drain removal, the most common symptoms were postoperative headache and giddiness, which persisted for up to 2 weeks. No major complications like meningitis, pneumocephalus have been seen in any of the patients. Discussion: the main aim of the present technique of endoscopic endonasal approach is to reduce the complications of external approach like brain compression, intracranial hematomas, seizures, anosmia, and higher rates of failure. The placement of lumbar drain reduces the chance of graft expulsion, mainly in patients with spontaneous CSF rhinorrhea and with intracranial hypertension. 3 patients with traumatic CSF rhinorrhea were given a maximal medical management of 10 to 14 days before the surgery, and after the failure of which we went for the surgery. CSF rhinorrhea is a condition which is socially troubling to the patient, but the main motive for repair is to reduce the risk of meningitis and other intracranial complications. The leak repair should be performed at the earliest reasonable opportunity to reduce the risk of meningitis. External approach has many intracranial complications, but also gives an external scar to the patient. Endoscopic endonasal multi-layer repair provides a better results cosmetically as well as in rates of recurrence. These are my references. Thank you.
Doctor, have you measured the CSF pressure during surgery or before
Yes,
starting the
sir.
surgery?
Yes, sir. We placed a lumbar drain before starting the surgery. So it was placed intraoperatively, and we've measured the CSF pressure using a three-way catheter, and then we have drained the CSF over a period of 5 days based on the patient's CSF pressure, sir.
Okay. So what was the average CSF pressure in all this spontaneous CSF leak?
So spontaneous CSF leak, it was more than 30 mm of H2O, sir, in most of the patients. But it was in supine position, it was more than 30 centimeters of H2O, sir.
So you were talking about the sphenoid sinus leak in one case where you used the
Sir.
Hadad flap,
Yes,
right?
sir. Yes, sir.
So which side Hadad flap you used?
Sir, we have used the Hadad flap on the left side, sir.
So you harvested Hadad flap from the left side and you have used ipsilaterally. You have used the ipsilateral Hadad flap, right?
No, sir. No, sir. Yes, sir. Ipsilateral Hadad flap was used, sir.
Okay. What happened to that vascularity for that flap?
So the nasoseptal artery is the vascularity for the Hadad flap, sir. Because as we have used it ipsilaterally, the vascularity has reduced a bit, sir. But there was no necrosis of the flap or anything in the post-operative period, sir.
Do you use
Uptake has
Diamox?
been good.
Do
Yes,
you
sir. We
use
used
Diamox also?
yes, sir. We used acetazolamide 250 mg, sir, in every patient.
Okay. Thank you. Thank you.
Thank you, sir.
That's a good presentation, Dr. Pranavi.
Thank you, sir.
Next, Dr. Maunika.
Sir.
Are you ready?
Sir, yes, sir.
Share your screen.
Sir, can you see my screen, sir?
Yeah, we can see. You can start now.
Sir, can you see my screen, sir?
Yes, yes.
Yeah, we can able to see your screen. You can start now.
Sir, can you see my screen, sir?
Yes, we can able to see your screen.
Sir. Can I start, sir?
Yeah, start.
Good morning, everyone. I'm going to present about endoscopic endonasal approach for inverted papilloma. Myself, Dr. Maunika. Introduction. Inverted papilloma is the second most common benign epithelial tumor of sinonasal tract. The tumor is well known for its invasiveness, tendency to reoccur, and associated with malignancy 5 to 15%. The incidence rate of inverted papilloma is 0.6 cases per 1 lakh people per year. It comprises 0.5% to 4% of all primary nasal tumors. It usually arises from lateral nasal wall. Traditionally, the surgery is performed by an open approach. Endoscopic approach has emerged as a minimally invasive alternate to open approach. Performing an open approach provides excellent exposure of the lateral nasal wall and maxillary sinus, ensuring good tumor clearance. Open approach can result in disfigured facial scar and may lead to prolonged crusting due to persistent changes of normal sinonasal physiology. With advances in endoscopic sinus surgery, it provides improved access to specific nasal areas and better visualization of the tissue. It also had shown potential advantages of shorter hospital stay with less complications of open surgery. Aim to report our institutional experience with endoscopic approach and combining with external approach for anterior wall of maxillary sinus for inverted papilloma, evaluating the surgical outcome. Materials and method. Study design. It's a comparative study. Study selection, ENT outpatient department. Study period 18 months. Sample size is 8 patients. Inclusion criteria: patients with age of 25 to 65 years are included, confirmed by histopathological report. Exclusion criteria: prior treatment to other conditions like malignancy and recurrent cases are excluded from the study. Methodology: in this study, the age of the patient is 25 to 65 years, 5 are males and 3 are females. The duration of symptoms of range between 6 months to 2 years. Nasal obstruction was a common symptom in most of the cases, whereas epistaxis, rhinorrhea, anosmia are also present. All patients involved in the study received a preoperative radiological assessment and accompanied by histopathological report. Here you can see the histopathological report of the inverted papilloma has endophytic growth pattern consisting of marked thickened squamous epithelial proliferation growing into downwards into underlying connective tissue stroma to form a clefts and ripples. In one patient, inverted papilloma seen in both nasal cavities involving the bilateral sphenoid sinus. This is the diagnostic endoscopy of right nasal cavity. The CT scan of the patient involving the bilateral sphenoid sinus. The intersphenoidal septum is present, absent in the patient. We have underwent the endoscopic resection of papilloma was done for this patient. We have approached medial to middle turbinate with a debrider. We have debrided the papilloma in the sphenoid sinus, and again the tissue is sent for histopathology. This is a post-operative diagnostic nasal endoscopy of the sphenoid sinus after 1 month. This is a post-operative diagnostic nasal endoscopy of the sphenoid sinus after 6 months. In one patient, we have underwent the combined approach due to involvement of the anterior wall of the maxillary sinus. The CT scan of the patient involving the left maxillary sinus and left nasal cavity. Patient is under general anesthesia. Patient is scrubbed and red. The Moore's incision is given here. The incision extended beside the ala, and the incision is further extended to the medial canthus. The removal of the papilloma was done and again is sent for histopathological report. In one patient, the inverted papilloma was arising from the left inferior turbinate and it is encroaching onto the other choana. Using microdebrider, we have resected the papilloma, and transorally we have entered because the papilloma was extending to the other choana. In one patient, inverted papilloma is involving the right anterior and posterior ethmoid. The CT scan of the patient involving the anterior and posterior ethmoids. In this patient, the patient underwent the polypectomy 13 years back, and he reoccurred with the inverted papilloma after 13 years. This is a diagnostic nasal endoscopy of the patient. We have debrided this papilloma. In one patient, inverted papilloma is involving the left nasal cavity and left maxillary sinus. This is the preoperative diagnostic nasal endoscopy of the patient involving the left nasal cavity. And this is the CT scan of the patient. You can see the left maxillary sinus is full of the papilloma. We underwent the endoscopic medial maxillectomy. First we infiltrated the inferior turbinate, and inferior androstomy is done, and the medial wall of the maxillary sinus is removed here. In my study, 5 are males and 3 are females. In inverted papilloma, in my study, in 8 patients, 1 is from bilateral ethmoid sinus and 3 are patients from left maxillary sinus. 1 patient is from right maxillary sinus, and 1 patient is from anterior ethmoid. 1 patient is from inferior ethmoid, and 1 patient is from anterior and posterior ethmoids. Inverted papilloma, in my study, we have underwent endoscopic approach for 7 patients and in combined approach for 1 patient. Discussion: endoscopic approach is increasingly replacing open approach, which previously we considered the preferable treatment for neoplastic disease involving the lateral nasal wall and maxillary sinus. Open approach alters the normal nasal physiology and may cause nasal crusting in addition to facial scarring. The complex sinus anatomy or tumor location and extent may also limit the applicability of this approach. For example, the disease that involves anterolateral maxillary sinus, the patient should always be advised of the possibility of performing concomitant combined approach. Conclusion: the endoscopic approach is a preferable option for the treatment of benign sinonasal neoplasm involving the medial wall of maxilla, specifically inverted papilloma. This technique has less morbidity and similar cure rates when compared with open approach. The adjuvant external approach may be performed when needed to allow complete eradication of the disease present. These are my references. Thank you.
Okay, doctor. How did you diagnose inverted papilloma prior to surgery?
Prior to surgery, we have sent the biopsies. We have taken biopsy from the patients of every patient, and we have sent it for histopathological reports.
And all the biopsy report came as inverted papilloma.
In some cases, it was came as polyp only, sir. Those cases are excluded from the studies.
After surgery, during surgery, how do you send all the specimen for biopsy?
Sir?
How will you send biopsy after surgery?
After surgery, some tissue was taken. The tissue was taken and sent for the biopsy, sir. Total mass was taken and sent for biopsy, sir.
Okay. What is the importance of sending all the tissue for biopsy?
To rule out malignancy, sir.
Okay, thank you.
Thank you, sir.
Dr. Soumya Niharika.
Yes, sir.
Are you ready?
Yes, sir.
Share your screen.
Sure, sir. Is my screen visible, sir?
Yeah, make it full screen. Yeah.
Yes, sir. Can I start, sir?
Yeah, you can start.
Good morning, sir. I'm Dr. Soumya Niharika Busi, and today I'm going to present a case series on management of pleomorphic adenoma in ENT. Introduction. Pleomorphic adenoma is most common benign tumor of salivary glands and typically occurs in parotid glands, less common in submandibular and minor salivary glands. Less than 10% of the salivary gland tumors arise from minor salivary glands and less than 3% occur in the submandibular glands. The most commonly occurring site of pleomorphic adenoma in oral cavity is hard palate. Other presenting sites include lip, buccal mucosa, or alveolar ridge, floor of mouth, and tongue in decreasing order of frequency. Pleomorphic adenomas of oral cavity tend to appear smooth and are relatively slow growing. Depending on the site and extension, the symptoms can be varied. It occurs in women more than men, especially between 4 to 6 decades of life. Etiopathogenesis of pleomorphic adenoma is known to be associated with alterations in proto-oncogene pleomorphic adenoma gene 1, which is activated due to variable chromosomal aberrations. Aim and objectives. This is a retrospective study of our institutional experience in diagnosis and management of ultrasonogram and fine needle aspiration cytology proven cases of pleomorphic adenoma from different sites, evaluating the surgical outcomes and complications. Materials and methods. It is a retrospective case series analysis in patients of 8 patients who underwent surgery for pleomorphic adenoma in our institution in over a period of 12 months. Inclusion criteria, histopathologically confirmed pleomorphic adenoma diagnosis, tumors located in parotid, submandibular, and minor salivary glands. Exclusion criteria, histopathological diagnosis other than pleomorphic adenoma, pregnant or breastfeeding women, recurrent tumors, tumors located in sites other than salivary glands. These are the, this is the surgical management in parotid pleomorphic adenoma. After administration of general anesthesia, patient was put in a hyperextension of neck and head is tilted towards the opposite side. Infiltration is given in preauricular, postauricular, and inferior auricular region. Modified blades incision is given starting from tragus around the ear lobule towards the mastoid tip and it curving down towards the neck crease. Ear lobule is retracted to clear it away from the surgical fluid. Anterior and posterior
Excuse me,
plasma.
doctor. Excuse me, doctor. We are not getting your video.
Sorry, sir. Am I visible now, sir?
Yeah.
Okay, sir.
Ear lobule is retracted from the surgical retracted using a suture to clear it off from the surgical field, and anterior and posterior flaps are elevated. After elevating the posterior flap, the greater auricular nerve, sternocleidomastoid, and posterior belly of digastric are exposed. The tail of parotid is dissected off from the sternocleidomastoid muscle, and the superficial lobe of the parotid is dissected after dissecting all of its attachments. And we can see the facial nerve here. Drain is placed after the surgery and suturing is done. These are the patients who underwent superficial parotidectomy. And these are the patients who underwent total parotidectomy, as there is a deep lobe involvement. Surgical management in palatal pleomorphic adenoma. After administration of GA, Boyles-Davis mouth gag is introduced and infiltration is given over the swelling. A palatodenticular incision is given and a flap is elevated medially, and the tumor thus identified is resected and denticular sutures are applied. These are the patients who underwent resection of the palatal pleomorphic adenoma. Surgical management in submandibular pleomorphic adenoma. This is the patient who underwent resection of pleomorphic adenoma in submandibular gland. Incision is made in the submandibular region around 5 to 8 centimeters. Incision is given and tumor is identified. Observation and results. This is the retrospective study showing the age of the patients is between 7 to 80 years. Duration of the symptoms ranging between 2 months to 3 years. Most of the patients complained it is a painless swelling, and others included difficulty in chewing and speech as well. One parotid pleomorphic adenoma patient had flap necrosis, which is reverted to normalcy, and another had transient marginal mandibular nerve injury of the ipsilateral side. While hard palate pleomorphic adenoma patients didn't have any post-surgical complications. All patients of this study had regular follow-ups and showed no signs of recurrence. This is the flap necrosis in a patient postoperative, which is seen in postoperative day 1. After POD 7, it is reverted back to normalcy after administration of adequate antibiotics. Another patient had a transient marginal mandibular nerve injury postoperatively. This is the POD pre-op picture, and this is the POD 0 picture, sir. 25% of this subjects are males, and 75% of the subjects are females, which is 6 females and 2 males. Pleomorphic adenoma of the cases analyzed, the involvement of parotid superficial parotidectomy is done in 3 patients, and total parotidectomy, as there was deep lobe involvement, is there in 2 patients. Palatal resection was done in 2 patients, and submandibular gland pleomorphic adenoma was done in 1 patient. These are the age and involvement of parotid or palate or submandibular gland in other patients. Discussion. The diverse presentation of pleomorphic adenomas make diagnosis complicated and challenging, while their occurrence in minor salivary glands is uncommon. Obtaining the correct diagnosis as early as possible is essential, because early initiation of appropriate treatment allows for effective management and improves the patient prognosis. Pleomorphic adenomas, small, mobile, with a clearly observed capsule located in the superficial lobe or tail of the parotid gland, can be removed by limited surgery with few complications like temporary or permanent facial nerve palsy. Freeze syndrome or gustatory sweating, and parotid cancer development. Superficial parotidectomy, total parotidectomy, and extracapsular dissection replaced enucleation technique. Alternative, really novel therapeutic approach might consist in injecting the patients with autologous endothelial progenitor cells to accelerate the revascularization. Conclusion: pleomorphic adenoma of submandibular gland.
Time up.
Okay, sir.
Okay, thank you. The next.
Okay, sir. Dr. G. Sravan Kumar.
Good morning, sir.
Yeah,
Am I
good morning.
audible,
Are
sir?
you ready? Yeah, you are audible.
Yes, sir.
Share your screen, please. Are you ready, Dr. Shravan?
Yes, sir. Just this one. Let's go. Hangout, sir.
Do you need some time, Dr. Shravan?
Sir, just 1 minute, sir. It is not connecting, some technical issue, sir. Sir, can I present next, sir?
Yeah, okay, no problem.
After this. Sorry, sir.
No problem. Dr. Nida Ayesha?
Yes, sir. Am I audible, sir?
Yeah, you are audible. Are you ready?
Yes, sir. I'm ready, sir. Can I share my screen now, sir?
Yeah.
Is my screen visible, sir?
Yes, visible. Make it full screen.
Yes, sir. Good morning, sir. Today I'm here to present my case series on excision of tumors by transcribal approach as a road not taken. Why am I calling it as a road not taken is because until recently, the tumors of the clivus and the posterior cranial fossa were considered extremely difficult to access and were considered inoperable using the standard transcranial approaches because they had very circuitous route and it involved excessive bone drilling and brain retraction. These procedures were not used and it causes major injury to the neurovascular structures. With the introduction of this minimally invasive endoscopic route in the neurosurgery, it's a boon and it helps us to access the hard to reach tumors with minimal impact on the brainstem. So the various tumors which can be excised using this route are the chordoma, meningioma, to name a few, the most common being the chordoma and meningioma. My aim here is to highlight the importance of excision of tumors by transcribal approach. Coming to the material and methods of my study, it's a prospective study which was done in our hospital from January 2023 to 24. Out of the 10 cases which presented to the hospital, 5 of them gave consent for the surgery and were followed up for a period of 6 months. Age and sex distribution, 60% of them were females and were above 40 years of age. The most common presenting complaint was headache, followed by nasal obstruction and diplopia. 2 of the patients had facial pain, and 1 of them had flexion and extension problem. Patient underwent clinical, ophthalmological, neurological, and endocrinological examination. Before surgery, all the patients underwent high-resolution CT scan with 3 different views. To determine the relationship of the tumor with major blood vessels, MR imaging with and without contrast was done, followed by CT angiography and MRI angiography. I would like to present 2 interesting cases. One 12-year-old female presented to the OPD with the symptoms of headache and nasal obstruction. On taking the CT scans and the MRI, we have noted a swelling in the clival region, which was causing a compression in the cervicomedullary junction. This, as you can see, the first scan is indicating of the junction compression, and post-surgery, we can see there's a relief in the compression. A smart navigation system was used. This uses the pre-operative helical CT data from the patient, and it creates an anatomic map which will help us to adequately locate our instruments while doing the surgery. I would like to briefly mention my operative steps. Coblation adenoidectomy was done, which was followed by sphenopalatine infiltration, followed by middle turbinate resection. Sphenoidotomy was done, showing to locate the optic nerve and the internal carotid artery, which was followed by posterior septectomy and palatine crest drilling. Nasopharyngotomy led to the exposure of the paraspinal musculature, that is nothing but longissimus capitis and longissimus coli. C1 arch exposure and dissection was done, followed by clival drilling. C2 dense exposure and drilling was followed. Tumor was removed in toto. Hemostasis was secured using the Surgicel and the Abgel. Nasopharyngeal flaps were closed. I would like to show a few intraoperative images. This is the first image is showing after sphenoidotomy. We can see the outside appearance. Here, a second image is showing after nasopharyngotomy. We can see the exposure of the longissimus capitis and the longissimus coli muscles. This is the clival drilling and the C2 dense drilling. This is the status after the adenoid process odontoid process have been removed, and this is the picture. The second picture is showing the nasopharynx before the flap closure. Here we can see after the flaps have been closed and the tumor has been removed. This is the oropharynx at the end of the procedure. So the chordomas are the rare malignant tumors, lesion derived from the embryonic notochord. Though they are having a slow growth and low-grade histology, they are having a very aggressive behavior and a high rate of recurrence. So that is the reason post-surgical excision we have to subject the patients for radiation therapy. The clival chordomas are extradural, exophytic, and lytic lesions centered on the clivus and are managed differently when compared to those rising from the sacrococcygeal region, because the neurological functions have to be preserved while doing the surgery. My second case is a female who presented to the OPD with the symptoms of a nasal obstruction. Here we can see a diagnostic nasal endoscopy video. The probe is being passed from the right nasal cavity, and we can see a tumor in the nasopharyngeal region. On taking the CECT and the MRI scans, we came to the conclusion of a case of clival chordoma, as the T1 weighted image showed us low to intermediate signal intensity image. On T2 image, there was a high signal intensity image. This is the post-op resected specimen of the clival chordoma, and the CECT was taken post-surgery, and it confirmed the presence of clival chordoma. Post-op follow-up of the patients was done using the CT scans and the MRI with and without contrast, as well as the endoscopic examination was done. This is a picture of the same patient post-excision taken on day 15th. I would like to discuss a few points regarding the transclival approaches. As this is a full endoscopic procedure, it requires no traction of the brain structures, and it has an extended visualization of the extra-intradural space from the crista galli to the craniovertebral junction, and even in the most inaccessible regions. There's no need to displace the vertebral artery. But there are certain limitations also to this approach. When the tumor is extending laterally, or if it is involving the orbital, or if it is extending beyond the clinoid process, we have to go for the transcranial approaches. To conclude, I would like to say that being a minimally invasive procedure, it has less post-operative morbidity and complications when compared to the transcranial approach, and it is an alternative to transcranial approach, and the results of this are comparable with the transcranial approach, and sometimes even better when compared to that. These are my references. Thank you.
How do you reconstruct the clival defect?
We have used the flaps, sir.
What flap?
Facial lata flap we have used, sir. And the bone
You
graft.
used a free mucosal flap, free mucosal
Yes.
and facial lata, free graft.
Yes, sir.
What were the complications that can occur?
The complications that can occur is the CSF rhinorrhea and meningitis, sir. One of the patient had a CSF rhinorrhea, and we managed it conservatively, sir. And post odontotomy excision, the patient can have this spine abnormality, so we have to support the spine also post surgery.
So how do you choose whether you have to go by transnasal approach or a transoral approach? Is there any demarcation to select which approach will be suitable for this case
Yes, sir.
in odd and rad?
Yes, sir. On taking the CT scans, if there is a well pneumatized sphenoid and if the distance between the internal carotid artery on both the sides is like minimum 10 centimeters in the adults and minimal 12 centimeters in the pediatric age group, we can go by the transclaval route.
Okay, thank you.
That's a very good presentation, Dr. Nida Ayesha. Dr. Shravan, are you ready? Dr. G. Shravan Kumar. Okay. Dr. Nikhil Kumar.
I think we have missed Dr. Divya Rani.
Yes, sir. Yes, sir.
Sir, Divya Rani, we will ask her to present at the end of all presentations.
Okay, sir. Okay.
Dr. Nikhil Kumar. Dr. Nikhil Kumar, are you ready?
Yes, yes, sir.
Very well, please.
Sir, I'm unable to share my video, sir.
Okay.
Hello?
Sir, you want to go with Dr. Divya Rani's presentation, sir?
Yeah, no problem, sir. You can.
Dr. Divya Rani, are you ready? Dr. Nikhil, are you encountering any problem?
Yes, sir. I'm unable to open. I think you need to give me permission to share my desktop, I think.
Yeah, please.
Bhani sir बोले very good presentation बोले.
Dr. Mohit.
ये श्रवण कुमार का नहीं था, तो नहीं मेरा है. नहीं आया, मेरे से पहले एक वाला नहीं आया.
Dr. Nida Ayesha, please mute yourself.
Yes,
Dr.
sir.
Mohit, are you ready?
Yes, sir.
Yeah, start sharing your screen, please.
Yes, sir. Sir, do I start?
Yeah, now you can.
Okay, sir. Good morning, sir. Good morning, everyone. I'm here to present my study, outcome of septoplasty alone and septoplasty with middle maple anthrostomy in patients with deviated nasal septum.
Yeah, adding so that.
Nasal obstruction is the most common complaint faced by an ENT surgeon in every practice. Deviated nasal septum is most common cause of nasal obstruction leading to sinusitis. With the introduction of endoscope in the field of ENT, there were many efforts used to use it for correction of deviated nasal septum and also clear the sinus disease in the same setting. In this study, we want to compare the outcome of septoplasty alone and septoplasty with bilateral middle maple anthrostomy in patients with deviated nasal septum. My aims and objectives to study the outcome of septoplasty alone and septoplasty with bilateral middle nasal anthrostomy in patients with symptomatic deviated nasal septum. Objective: to assess the similarities and differences in the functional outcome of patients who have undergone septoplasty alone and septoplasty with bilateral middle nasal anthrostomy. Materials and methods. Patients attending outpatient department with symptomatic deviated nasal septum were included in the study. It's a prospective comparative study with a sample size of 100 people. Data was collected by selecting patients with deviated nasal septum who were willing for surgery. Patients were divided into two groups. Group A underwent septoplasty alone, and Group B underwent septoplasty with bilateral mid-metal androstomy by random selection, and they were followed up for a period of 6 months. Inclusion criteria. All the patients between 18 to 60 years with symptomatic deviated nasal septum were included in the study. Patients with traumatic deviated nasal septum and spur were included in the study. Exclusion criteria. All the patients less than 18 years of age or more than 60 years of age were excluded, with patients with asymptomatic deviated nasal septum, with allergic rhinitis, acute rhinitis, nasal mass, nasal polyposis, and patients with proven sinusitis were excluded from the study. My observation and results, most patients in our study with symptomatic deviated nasal septum fell in the age group of 30 to 40 years, followed by 20 to 30 years. The outcome of the study did not get much affected with the age of the patients. Symptoms. In our study, most common presenting complaint was nasal obstruction, followed by headache, post-nasal drip, nasal discharge. One patient presented with epistaxis who was placed in septoplasty plus mid-metal androstomy group. Our diagnostic nasal endoscopic findings. Most patients in our study had left-sided deviation, followed by right S-shaped DNS. Spur was found in 17 patients. Radiological findings. Septal deviation was seen in all the 100% cases. 64% cases had obstruction to osteometrial complex drainage. Hypertrophic inferior turbinate was seen in 24 patients. All the patients with sinus haziness were excluded from the study. Outcome. In patients in Group A underwent septoplasty alone, nasal obstruction was relieved in 64% of the cases and was relieved in 70% of the cases in septoplasty plus mid-metal androstomy group. Headache was relieved in 73% patients in Group A and 83% patients in Group B. Post-nasal drip was relieved in 62% patients in Group A and 70% patients in Group B. Nasal discharge was relieved in 68% patients in Group A and 72% patients in Group B. Epistaxis postoperatively relieved in patient that underwent septoplasty plus mid-metal androstomy. Our study is a randomized controlled trial with 100 patients with symptomatic deviated nasal septum in the age group of 18 to 60. It's a prospective study where 50 patients underwent septoplasty alone and 50 patients underwent septoplasty with mid-metal androstomy. The average age of the patients was 37.28 years. Most patients had nasal obstruction as a presenting complaint, followed by nasal discharge, headache, and post-nasal drip. The diagnostic nasal endoscopy in all the patients had deviated nasal septum. Left-sided deviated nasal septum was common, followed by right, where S-shaped deviation. Preoperative CT scan showed obstruction to nasal drainage of osteometrial complex in 64% of the patients. In patients with nasal obstruction, 64% had relief in septoplasty group and 67% were relieved in group B. Nasal discharge was relieved in 68% patients in Group A and 70% patients in Group B. Headache was relieved in 73% patients in Group A and 81% of patients in Group B. Post-nasal discharge was relieved in 62% patients in Group B and 70% patients in Group B. Post-op hyposmia, epistaxis were not seen in any patients who underwent either surgery. Inferior turbinate hypertrophy was reduced in 61 patients in Group A and 70% patients in Group B. Surgical options appear to be equally effective with no statistical significant difference in outcomes measured in our study. Conclusion. The study was done to compare the functional outcome of septoplasty alone and septoplasty with mid-metal androstomy in patients with symptomatic deviated nasal septum. In our study, surgical options appear to be equally effective in terms of postoperative symptomatic relief and postoperative nasal endoscopic findings. Even among patients who were radiologically showed obstruction to drainage of osteometrial complex, septoplasty with mid-metal androstomy showed little or no additional benefit over septoplasty alone. With our study, we conclude that septoplasty alone is an adequate treatment option for patients with symptomatic deviated nasal septum. This is my review of literature. These are my references. Thank you, sir.
Thank you.
Thank
you. You can move on, sir. You can move on.
Thank you, sir.
Okay, sir. Dr. Nikhil.
Hello?
Yeah, Dr. Nikhil, can you share your screen?
Yes, sir. Is it visible, sir?
Dr. Mohit, you have to stop sharing your screen first. Yeah, Dr. Nikhil, are you sharing your screen?
So I think Mohit should remove his shared screen, sir.
Yeah, okay. Dr. Mohit?
Still, I'm facing problems, sir. Can I go next, sir? Hello? Hello, sir.
Okay, we'll be getting back to you at the end.
Okay, sir.
Sajja Nagarjuna?
Good morning, sir. Can you hear me, sir?
Yes.
Hello, good morning, sir.
Yeah, good morning. You can start
Good
your
morning, sir.
presentation.
Can I start my presentation, sir?
Yeah, you can start.
Thank you, sir. Myself, Nagarjuna. The title of my series is Enigmatic Caverns Variations of the Sphenoid Sinus. The sphenoid sinus stands out as one of the most unpredictable cavities in the human body, often presenting unique variations that can complicate access. It nestles near several vital structures. It poses challenges for the surgical exploration and intervention. This intricate relationship underscores the importance of recognizing the numerous anatomical variations that arise, making a thorough understanding essential for anyone working in this field. Aim of my study is to evaluate the prevalence of the anatomical variations of the sphenoid sinus and its relations to the surrounding vital structures on CT of paranasal air sinuses. My study design is a cross-sectional study. Duration is of 1.5 years from January 2023 to July 2024. Study population is 100 patients. Inclusion criteria, all the patients who are advised computed tomography for paranasal sinuses, and the patients who had trauma, prior history of prior surgery of sphenoid sinus and sinus nasal tumors that alter sphenoid sinus anatomy were excluded from this study. I conducted a study of 100 CT scans of paranasal sinuses. All coronal, axial, and sagittal sections were analyzed for anatomical variations variations of the sphenoid sinus dominance and the presence of hornidal cell, and based on the pneumatization of the body of the sphenoid and the extension of the pneumatization, and neurovascular relationships that include protrusion and dehiscence of the internal carotid artery, optic nerve, and the intersphenoid sinus septum attachment to them. My results of my study, among 100 patients, 55 are male and 45 are female, almost equally distributed. And the dominance of the sphenoid sinus, almost it is in 50 patients, it is symmetrical, and it is right dominant in 24 patients and left dominant in 26 patients. And based on the pneumatization of the body of sphenoid in relation to the Sahasra Tikka, 78 patients showed cellular type of pneumatization, and 18% showed precellular, and 4 patients showed conchal type of pneumatization. And the pneumatization extending into the anterior coronal process produces a deep recess between the optic nerve and the internal carotid artery, known as carotico-optic recess. And if the pneumatization is extended much more laterally into the pterygoid process at the greater wing of sphenoid, it can produce it is known as lateral recess. In this two coronal views, one is showing anterior cleaner keratoco-optic recess, and the other showing the long arrow showing the lateral recess and the short arrow showing the median node. Based on the extension of the pneumatization of the anterior cleaner process, 29 patients have, among 100 patients, 29 patients have anterior cleaner process pneumatization, bilateral in 14 patients, 7 in right side and 8 in left side. And the pterygoid process pneumatization in 33 patients, it is showing pterygoid lateral recess, and 22 is showing bilateral, 6 patients are showing right, and 5 are having left. And the posterior ethmoidal cells extending in much most posteriorly into the sphenoid over the sphenoid sinus. In these cases, the optic nerve produces direct bulge into the onody cell rather than into the sphenoid sinus. Both the images are showing the right onody cell. In 100 patients of this study, 31 are showing onody cells. 10 patients have bilateral, and 12 are having right, and 9 patients are having left onody cell. Based on the attachment of the intersphenoidal septum, it can attach to either internal carotid artery and optic nerve. In this axial section, it is showing attachment to the coronal carotid artery. In the coronal section, it is showing attachment to the optic nerve. In my study of 100 patients, 12 patients have attachment to 12 patients of having attachment to the internal carotid artery. 7 are to the right, 5 are to the left, and to the optic nerve. 18 patients are having attachment to the optic nerve. 10 are having to the right, and 8 are having to the left. This is the overall summary of the variations of the anatomical variations of sphenoid in my 100 patients, including pneumatization, protrusion, dehiscence, onody, and attachment of the intersphenoidal septum. Summary of this cellular type is seen in the most common is the most common sphenoid sinus pneumatization in my study, showing in 78%. Prevalence and extent of the pneumatization included into the cleaner process, pterygoid process in the greater ring of sphenoid was in 29, 33, and 7 respectively. Attachment of the intersphenoid septum is in to the internal carotid artery in 12 patients, and to the optic nerve in 18. Protrusion of the internal carotid artery, optic nerve, maxillary nerve, and median nerve is seen in 7, 7, 3, and 4 respectively. The dehiscence is of these structures is seen in 3, 8, 3, and 4 respectively. Pneumatization of the onody cell is seen in 31% of the patients. Discussion during FES instrumentation to remove disease posteriorly or posteriorly and superiorly into the sphenoid sinus should be conducted very carefully by observing the pneumatization into the anterior cleaner process. Should be careful with the internal carotid artery, optic nerve, and skull base. If the pneumatization is extending much more laterally into the pterygoid process, 30-degree angled endoscope is better to use to clear the debris and to irrigate the debris and to remove it. The microdebrier should not be used on the lateral wall in the presence of even in the presence of polypoidal tissue to avoid injury to the internal carotid artery and the optic nerve. Septation should not be necessarily removed because of its attachment to the internal carotid artery and optic nerve. The prevalence of this study was comparable with the previous studies, but still there have been variations among different studies in the literature all over the world. So still the approach of the sphenoid sinus still remains a clinical challenge despite the arrival of the endoscope, CT, and advancement in the functional endoscopic sinus surgery. So computer tomography with axial, coronal, and sagittal planes should be routinely used and thoroughly studied for the it is the initial work of the patients undergoing FES, particularly including with the sphenoid sinus surgery. These are my references. Thank you, sir.
Do you know any classification of sphenoid sinus pneumatization with regard to optic nerve relationship?
Yes, sir. The Danlos classification is there based on the optic nerve. There are 4 types of pneumatization with regarding to the optic.
What classification?
Danlos classification, sir.
Do you know anything like Fun-Delano-Zinrich classification? Have you heard about Fun-Delano-Zinrich classification?
Yes, sir. Delano's classification, I heard there are 4 types of based on the protrusion of the optic nerve into the sphenoid. Sphenoid.
Okay, thank you.
Yeah. So good morning, sir. Yeah, this first session was ended now, so concluded now.
Okay, sir.
Thank you, the judges, Dr. P.T. Nagaraj, sir, and Sharvana Selvan, sir.
Thank you,
so much for your time and patience.
Thank you, sir. Thank you.
Sir, Nagaraj, sir, thank you so much, sir. Yeah, now I'm going to invite the next session judges, Dr. M.N. Shankar, sir, from Chennai. And Dr. Somu Lakshmanan, sir. Sriharsha, these are a series of the judges. Please. Somu sir is on the way, I think. Just wait for 2 minutes. Once Somu sir joins, we'll start.
Am I being heard, sir?
Sir,
Hello?
good morning, sir.
Good morning, sir. You are able to hear me, sir?
Yeah, welcome, sir. Welcome, warm welcome, sir. Yeah, we're waiting for the Somu Lakshmanan, sir. Just a minute, I will. Yeah, just for some time. Wait for some time. Sir is on the way because of technical issue. He's unable to join. Next candidate, please check your presentation. In the meanwhile. Dr. Funny.
Sir.
Invite next candidate. Just keep it ready.
Okay, sir.
Once sir comes,
Dr.
I will.
Nauma, Dr. Nauma, are you ready? Dr. Geetanjali?
Hello. Hello.
Good morning, sir.
Morning, sir. Morning, sir.
Welcome,
Sorry for the delay, sir.
No issue, sir. We'll proceed. We can proceed, sir.
Sure. Thank you, sir.
Call the next candidate and go ahead.
Yes, sir. Yes. Sir, welcome Dr. Shankar sir and Somu sir.
Thank you,
Sir,
sir.
in this session, we will be calling upon the presenters from serial number 19 to 28, sir.
Sure, sir.
And in the previous session, due to some technical disturbances, 3 presenters couldn't able to present. Serial number 3, serial number 14 and 16. We will be calling upon these presenters at the end of our session, sir.
Okay, sir.
And just to mention their numbers during the presentation.
Sure, sir.
Okay.
Dr. Nauma Sarin, are you ready? Dr. Geetanjali. Dr. Nagaraju. Dr. S. Kavya.
Sriharsha. Sriharsha, are you there? Sriharsha.
Sir,
Stop sharing that.
I stopped it, sir.
Yeah. That's a difficulty. So make the judges co-host. Dr. Heman Shankar sir and Somu Lakshmanan sir. Presenters, are you ready?
Dr. Nauma Sarin, Dr. Geetanjali, Dr. Nagaraju. Please respond who are ready. Dr. Kavya. Dr. Madhumita.
Yes, sir. Yes, sir.
Are you ready?
Yes, sir.
Yeah, please share your screen.
Yes, sir.
Sir, now we are going with serial number 23, Dr. C.H. Madhumita, sir.
Okay, sir. Fine.
Yeah, Madhumita, share your screen.
Yes, sir. Yes, sir. I'm sharing, sir. Sir, can you see my screen, sir?
Yeah.
Okay. Just
Make
a
it
minute,
full
sir.
screen.
Okay, sir. Yes, sir. Good afternoon, sir.
Yeah, you will be having 8 minutes. Go ahead.
Okay, sir. Yes, sir. I'm presenting a study on endoscopic optic nerve decompression for non-traumatic compressive optic nerve neuropathy in pediatric age group, sir. A transethmoidal optic canal decompression was first performed by Seville in 1960. Endoscopic approach is minimally invasive and is preferred for pathologies affecting the intracanalicular part of optic nerve. Non-traumatic compressive neuropathy is a rare occurrence and can be secondary to tumor, infection, bone dysplasias, etc. Our aim is to study the experiences with transnasal endoscopic optic nerve decompression in pediatric populations for non-traumatic compressive optic neuropathy. A retrospective study was conducted at our tertiary care centers on subjects who were operated by endoscopic optic nerve decompression and who gave the consent for the same between March 2023 to August 2024. All the subjects diagnosed with optic neuropathy recent 14 years of age were included, and traumatic causes of optic neuropathy was excluded. A transnasal endoscopic approach was chosen, and outcomes were measured based on visual acuity improvement. Age and sex distribution showed 10 to 15 years of age was the most common age group in our study population, with female more than male. Decreased vision was the most common complaint, followed by proptosis, double vision, periorbital edema, respectively. Unilateral eye involvement was most commonly seen.
All the patients were evaluated preoperatively with analysis of visual acuity, visual fields, color vision, fundoscopy, and visually evoked potential selectively. Radiological assessment was done with computer tomography of paranasal sinuses and orbit, MRI brain with orbits, plain and contrast. Surgical procedures chosen were endoscopic transnasal transsphenoidal optic decompression alone, or orbital decompression with optic nerve decompression. And postoperatively, visual acuity was evaluated at 2 weeks, 4 weeks, and 6 weeks respectively. 2 patients presented late after the inset of optic atrophy and were then intervened late. 3 were devised with optic nerve decompression alone, and 4.
Excuse me, Dr. Madhumita, you are
Yes,
not
sir.
visible to us.
Sorry, sir. 1 minute, sir. Let me fix that for you. Can you see me, sir? Sir, can you see me?
Yeah,
Am I
yeah,
visible,
okay.
sir?
Yeah,
Okay,
yeah,
sir.
go.
Yes, sir. 3 patients were dealt with optic nerve decompression alone, and the rest were adjuncted with the procedure of orbital decompression. This table shows different compressive etiologies presenting to our study with preoperative visual acuity assessment at the time of presentation and postoperatively at 2 weeks. Visual acuity improved in 5 patients and was stable in 2 patients, and it did not deteriorate. Here I want to discuss 2 cases which were interesting. One was of a 5-year-old female presenting with gradual decrease in vision in left eye, decrease in hearing for 2 weeks, and diagnosed with Chiari malformation with hydrocephalus. Visual acuity was reduced to hand movements positive in left eye, and visually evoked potential showed anterior visual pathway involvement, left more than right. CT paranasal sinuses showed caliveolar hypertrophy and sclerosis. Optic canal stenosis was seen, suggestive of craniotubular dysplasia. MRI of the same showed stenosis of optic canal and atrophy of optic nerves. This is a series of videos showing transnasal transsphenoidal optic nerve decompression, in which we have done a sphenoidotomy followed by drilling of the optic canal. And then the bone chips were flickered and optic nerve was decompressed in the intracanalular part. Bilateral optic nerve decompression was done in this patient, and visual acuity improvement was subjective. And this case as such has a poor prognosis. This next case is of a 12-year-old male child who presented with stumbling and constantly searching for objects since past 3 weeks. On slit examination, anterior segment was normal. Fundus examination showed diffuse disc pallor bilaterally. An MRI of paranasal sinuses showed hyperpneumatization of the sphenoid sinuses and frontal sinuses with pneumatization of anterior clinoid process and compression of optic nerve and optic atrophy. A transnasal orbital decompression with optic nerve decompression was done in this case. These are the steps showing medial meatal enterostomy, anterior ethmoidectomy, posterior ethmoidectomy, orbital decompression, sphenoidotomy, and optic nerve decompression on the right. Postoperative day 7 visual acuity improvement was to 6/12 from 6/60 preoperatively. Coming to results, 5 patients showed improvement in visual acuity and 2 had no improvement. Rather, they did not show any deterioration. Early intervention had better results, and no complications were encountered during the procedures, implying its safety in pediatric population. Results, Luxemburger et al. Commented on 7 cases of optic nerve decompression. For non-traumatic cases, all the cases benefited from the procedure. Stephen et al. Concluded that optic nerve decompression holds good for restoring vision in selected patients with compressive neuropathy. Leong compared different approaches and said that the transnasal approach had the least complication rate of 5.2%. Due to limited literature, we cannot generalize the conclusions, but we have to discuss few cases wherein there was a trouble of improvement, as in case 1 of craniotubular dysplasia, where there was subjective improvement, and the chances of recurrence are high in this case as the underlying conditions progress. And in case 3 of venous lymphatic malformation, where the patient presented with complete optic atrophy and no vision improvement was seen postoperatively. Concluding, we want to emphasize that optic nerve decompression due to non-traumatic causes, when diagnosed and amenable for operation through endoscopic approach, it has to be dealt endoscopically, as it forms the best approach with minimal complication rates and its safety profile in pediatric population. These are my references. Thank you.
Thank you, Madhumita. I think the first thing you put in a slide is inclusion less than 14, and next slide you put it as 0 to 15. Probably you could have put it less than 15 the first slide itself.
Yes, sir. Yes, sir. Okay, sir.
And you said the first child, he had a optic nerve atrophy.
Yes, sir.
So did an optic nerve atrophy help in doing a decompression? What was the aim in it?
Sir, optic nerve compression led to vascular compromise and optic nerve atrophy was set in before the patient was brought to us, sir. So the hand visual acuity was preoperatively, it was reduced to hand movements positive. And we had
No, my
to.
question was
Yes.
I remember saying that the first kid was optic nerve atrophy.
Yes, sir. In the scan,
So
it
now
showed
optic nerve atrophy. Does optic nerve decompression help?
No, sir. If there is a complete atrophy with irreversible changes, it will not help, sir. But if
So then why decompression was planned in optic nerve atrophy?
yes, sir, it was not complete, sir. The patient still had perception of light positive and he still had hand movements positive, sir. So we wanted to go in for a optic nerve decompression and see if there is an improvement, sir.
How long
Thank
will you
you.
wait?
Sir?
When will be the earliest you will do an
Yes.
optic nerve decompression?
Yes, sir. In cases of a non-traumatic etiology of compressive optic neuropathy, we have to deal in as early as possible, sir, to prevent any compressive changes and further deterioration of vision in the child.
What do you
Because
think is the cause for the optic atrophy?
Sir?
What is the cause for the optic atrophy?
Optic atrophy, the cause for optic atrophy is the pressure exerted by the pathology leading to vascular compromise due to the limited space of the orbit and also the optic canal.
What
and
is the blood supply of the optic nerve?
Ophthalmic artery, sir.
Where does it enter?
Sorry, sir?
Where does it enter the nerve?
Yes, sir. It
What is
enters
the percentage of various entrance?
The ophthalmic nerve traverses through the optic canal along with the optic
Where?
nerve infromedially, sir.
Where? Which side?
Infromedial to the nerve, sir. Sir, it enters in the infromedial quadrant, sir.
What will happen if you injure?
There will be torrential bleed, sir, and irreversible optic visual damage will happen, sir.
What precautions will you take?
While decompressing the optic nerve, we have to decompress it in the superior or the middle portion of the optic nerve and should not decompress in the inferior part of the optic nerve, sir.
How far will you decompress?
Yes, sir. In cases of a traumatic etiology, it is said that we have to decompress it 1 centimeter.
Non-traumatic, right?
Yes, yes. Non-traumatic etiology, it is ideal to decompress it from the annulus of Zinn to the optic chiasm, sir. That is all along the path of the intracanalicular portion, sir.
Thank you.
Thank you, sir.
Thank you, Madhumita.
Thank you, sir.
Yeah, Madhumita, that's a good presentation.
Thank you, sir.
Okay, stop sharing your screen.
Yes, yes, sir. Yes, sir. Just a minute, sir. Give me a minute, sir.
Dr. Nauma Serin, are you present here? Dr. Nagaraju, Dr. Kavya. Madhumita, stop sharing your screen. Dr. C.H. Hema Sahiti.
Yes, sir. Okay.
Share your screen, please. Make it full screen.
Proceed.
Make it full screen, please.
Is it visible, sir?
It is visible, but make it full screen.
Oh, yes, sir.
You click on slideshow. Yeah.
Yes, sir.
Sir, she is 24, sir. Hema Sahiti.
Yeah.
Yes.
Now you can start, doctor.
Yes. Good morning, sir. Today's topic is adenoidectomy and myringotomy with chroma insertion in otitis media with effusion with hearing loss, a case series. Otitis media effusion or glue ear is defined as the middle ear effusion without signs or symptoms of an acute infection of otalgia, otaria, fever, and irritability. It may occur spontaneously because of poor eustachian tube function or after acute otitis media. Otitis media effusion results in conductive hearing loss, averaging 30 decibel hearing loss. Hearing loss is significant, especially if bilateral, lasts longer than 3 months, or if the child already has cognitive speech and language delay. It can delay the speech and language, alter the behavior, resulting in erosion of the ossicles, impair the eardrum integrity, increase the risk of cholesteatoma, and negatively impact the quality of life. Candidates for myringotomy and Grome insertion include children with otitis media effusion lasting 4 months or longer with persistent hearing loss or other signs and symptoms, recurrent or persistent otitis media effusion in children at risk regardless of hearing status, and with structure damage to the tympanic membrane or the middle ear. The hearing level improves by 6 to 15 decibels when tubes are patent. Approximately 20% to 50% of children having otitis media effusion relapses after tube extrusion that may require repeated surgery. Adenoidectomy is recommended for those who require repeated surgery unless contraindicated because it gives 50% of reduction of repeat operation. Objective: otitis media with effusion can lead to hearing loss. Adenoidectomy with myringotomy and ventilation tube insertion are used in the management of otitis media effusion. This study aimed to know the outcomes of myringotomy with Grome tube insertion in children with this effusion in a tertiary care hospital. Materials and methods: a total of 20 cases were studied. Group 1, 10 patients underwent myringotomy with Grome insertion, and Group 2, who underwent adenoidectomy in addition to Grome insertion. The inclusion criteria is 5 to 12 years of age, chronic otitis media with effusion with no resolution after a period of time, not less than a 3-month duration, a conductive hearing loss of not less than 25 decibels, persistent tympanometry test of either type B or C result. And exclusion criteria is older than 12 years of age, any improvement of middle ear effusion during the first 3 months of the disease. The diagnosis is based on the detailed history taking thorough otoscopic examination followed by putone audiometry. Cases were subjected to either X-ray nasopharynx, late review, or endoscopic examination according to their cooperation to assess the adenoid hypertrophy. All cases presenting with the hearing gap of average loss of at least 25 decibels and fulfilling the inclusion criteria were included in the study. The operative technique: under aseptic conditions under general anesthesia with the help of a 0 degrees endoscope, small nick was given in anterior inferior quadrant of the tympanic membrane with the help of a myringotomy. Shepherd Grome was inserted in that insertion. Adenoidectomy was done in the required patient based on the symptoms and the X-ray nasopharynx. The follow-up: the degree of the preoperative conducting hearing loss and postoperative hearing gain, which referred to the improvement of airborne gap thresholds after the operation, were compared. Presence or absence of otorrhea was monitored and compared pre and post-op. A repeat tympanometry was performed 6 weeks after the procedure to evaluate any recurrence, if any. Results: there were 20 patients who have Grome tube, 12 males and 8 females, aged between 5 to 12 years. 10 patients underwent adenoidectomy in addition to Grome tube insertion. The putone audiometry was used to measure the preoperative hearing loss among the patients with otitis media with effusion according to the type of the intervention they had planned to undertake. The mean airborne gap was used as a measure to assess the amount of hearing loss in the patients. The audiometry recording was done after 6 weeks post-operatively for all the patients who have undergone the various modes of intervention, and it was compared. The gender distribution: males are more common than the females, and the mode of intervention: myringotomy with Grome only 10 cases and adenoidectomy other 10 cases. And the comparison: putone audiometry pre-op in a myringotomy with Grome only, it is 27, and after post-op it is 14. Adenoidectomy with Grome is 28 pre-op and post-op is 13. Discussion: in our study, a total of 20 patients were checked for ear pathologies in which 12 were male, 8 were female, 60% were males. Adenoid hypertrophy was noted in 10 cases and adenoidectomy was done. The mean airborne gap was improved to 14 and 13 in hearing threshold after myringotomy, Grome, and after adenoidectomy with tube. A study conducted by Riding compared the myringotomy, tympanostomy tube and medical line of the treatment. He found that the tympanostomy tube and myringotomy produced significant improvement in hearing when compared to the medical line of the management. Coyle, in a study, compared the effects of the adenoidectomy, adenotonsillectomy, and ventilation tube. They found that at 6 months after surgery, there was an average of 15 decibel improvement in hearing threshold after adenoidectomy with tube insertion, 12 decibel in adenoidectomy, and 15 in ventilation tube insertion. In present study on comparing the various treatment modalities for studies with otitis media with effusion, adenoidectomy with Grome insertion had the best results in the case of adenoid hypertrophy along with the effusion. Conclusion, our studies showed that although both the surgical techniques are effective in treatment of otitis media with effusion, adenoidectomy with myringotomy with Grome insertion showed favorable results with fewer complications and better results in treatment of serous otitis media effusion if adenoid enlargement is present. These are my references and thank you.
What was the cause for the OMB in patients where you did not do adenoidectomy?
Sir?
What was the cause for OME in patients in whom you did not do adenoidectomy and why you didn't do adenoid? Or
In those cases, there was no adenoid enlargement, sir, in those children. And repeated upper respiratory tract infections leading to eustachian tube obstruction, leading to them otitis media effusion, sir. In those
tell me
cases,
some causes. Tell me some causes for OME without adenoid enlargement. Some autoimmune disorder.
Autoimmune disorders.
Producing OME.
Sir?
Autoimmune disorders producing OME.
OME auto.
Tell me the grading for adenoids.
Grade 1, sir. Obstructing. Sir?
What is the name?
Adenoid.
Name for the gradation. Does the grading affect the OME?
Yes, sir. There's no, sir.
Okay. Somo?
Yes, sir. Suddenly again, my net went off. I don't know. It's been intermittent happening. Nice presentation. Nice presentation, Hema. Only thing, what is new in this topic?
Yes, sir. If the children are having adenoid enlargement, it is better to do an adenoidectomy with Grome tube insertion so that the hearing gets improved better, sir.
I do understand. That's a routine, no? Anybody with the adenoid, we normally convince for an adenoidectomy. With obviously with the serous otitis media, we would think. What do you think is new in your thing for your presentation here?
If the patients are not having any symptoms for adenoid enlargement, need not go for adenoidectomy, sir. Only Grome tube insertion is better, sir.
So if adenoid is huge and then asymptomatic, you just put a grommet and come away.
Yes, sir.
You think that's right?
If they are asymptomatic,
you think your serous otitis media will settle down with a huge adenoid and just leaving the adenoid?
no, sir, it doesn't get subside. Only after removing the adenoids, it gets subsided, sir.
No, that's what, again, you're reverting your own statement now.
Yes, sir.
Anyhow, thank you.
Yes, sir. Thank you, sir.
Next presenter, Dr. Harsha Thakur.
Yes, sir, I'm present.
Serial number 25, Harsha Thakur.
Yes,
Share
sir,
your
present.
screen. Yeah, share
Yes.
your screen.
So is it visible?
Yeah, make it full screen.
Yes, sir. Very good morning to all the judges and all the doctors present here. I'm Dr. Harsha Thakur, and my topic for case series is a comparative study on septoplasty followed by tympanoplasty versus tympanoplasty alone in the patients with CSM tubotympanic disease in terms of graft uptake and hearing results. So introduction, chronic suppurative otitis media is a highly prevalent disease worldwide, causing chronic inflammation of the mucosa in the middle ear and mastoid cavity. It is characterized by persistent ear discharge with tympanic membrane perforation, otalgia, hearing loss, which causes financial burden and psychological trauma to the patients. CSM is one of the main indicators for tympanoplasty. The main aim of tympanoplasty is to improve hearing and achieve a disease-free ear with intact canal wall or canal down mastoidectomies for disease-free mastoids. The principle of focus is eustachian tube in middle ear disease. The functions of eustachian tube are mechanical ventilation, clearance, and immunological defense. It drains the secretions from middle ear via mucociliary transport system and prevents aspirations of these secretions back into the middle ear from nasopharynx. Factors as affecting outcomes of tympanoplasty are the eustachian tube dysfunction, secondary to DNS or infections in the sinonasal passages or aerodigestive tracts as well. In the present study, we observed that the improvement in eustachian tube dysfunction with septal corrections prior to the tympanoplasty will help tympanoplasty outcomes. The aims of the study are to evaluate the role of septoplasty in successful outcomes of tympanoplasty, to study the role of septoplasty in obtaining a disease-free ear, and to compare the surgical outcomes in terms of graft uptake and hearing results. Materials and methods. Sample size is 20 patients. Study period is 8 months, and study subjects are patients attending the ENT department, fulfilling the inclusion criteria, and written informed consent taken from the patients. Inclusion criteria is patients aged 18 to 60 years, CSOM with tubotympanic safe type disease, unilateral or bilateral, central tympanic membrane perforation, deviated nasal septum, and no discharge prior to the surgery for 4 weeks at least. The exclusion criteria is atochoondral disease with marginal perforation, age below 18 years and above 60 years, sensorineural hearing loss, traumatic perforation, CSOM with complications, and ASOM. A total of 20 patients suffering from tubotympanic disease were divided into 2 groups, Group 1 and Group 2. Group 1 had been treated with tympanoplasty alone, underlay technique with temporalis fascia graft. In Group 2, septoplasty preceded tympanoplasty. So the deviations in the septum, bony and cartilaginous, were corrected with septoplasty and the splints placed on either side of the septum. After 6 weeks, tympanoplasty was performed with temporalis fascia graft. Pre-operate follow-up for 3 months with 3rd month PTA has been taken. Pre-op and post-operative otological examination findings of all the patients were evaluated. The degree of pre-operative conducting hearing loss and post-operative hearing gain were compared. A detailed history was taken: onset, duration of otorrhea, number of otological infections per year, any previous ENT surgeries. Then clinical examination of the ear, nose, and throat done. Otoscopy, rhinoscopy, Pyoton audiometry, tuning fork tests, X-ray bilateral mastoids, X-ray PNS, diagnostic nasal endoscopy done. Examination under microscope of the affected ears were done to confirm the diagnosis. Age and distribution. Among the 18 to 30 years of patients, in Group 1, we had 1 patient, and in Group 2, we had 3 patients. Whereas 30 to 50 years, in Group 1, we had 6 patients, and in Group 2, we had 7 patients. From 50 to 60 years, we had 3 patients in Group 1 and 0 patients in Group 2. The youngest patient in the study was 20-year-old, while the oldest was 54-year-old. The average age for tympanoplasty in Group 1 was 30 years, whereas in Group 2, the average age was 26 years. Gender distribution. In Group 1, there were 6 males and 4 females. In Group 2, there were 7 males and 3 females. More incidence was seen in males than females in our study. Then graft success rate, harvested graft material, which was taken as temporalis fascia. In Group 1, 70%, that is 7 patients showed intact graft uptake. And then in Group 2, there were 9 cases who showed the good graft uptake. Residual perforation was seen in 3 patients in Group 1 and 1 patient in Group 2. Hearing outcomes, pre and post-operative PTA of the patients in both groups were compared. Post-operative airborne gap of less than 15 or equal to 15 decibels were considered a successful hearing outcome. Coming to preoperative PTA, PTA average of 20 to 30 decibels was seen in 7 patients in group 1 and 8 patients in group 2. More than 30 decibels were seen in 3 patients in group 1 and 2 patients in group 2. Post-operative PTA, which is airborne gap closure gain of less than 15 was achieved in 8 patients in group 1 and 9 patients in group 2. More than 15 decibels was achieved in 2 patients in group 1 and 1 patient in group 2. The mean airborne gap improvement in group 2 was 12 decibels after the surgery, and mean airborne gap improvement in group 1 was 14 decibels after surgery. Discussion. Tympanoplasty is one of the commonly performed procedures in the field of otology. It is to create a sound conducting mechanism in a well aerated mucosal line middle cleft is the goal of tympanoplasty. Graft uptake rate in terms of graft uptake, it was significantly higher in group 2 in our study. The successful closure can be related to septoplasty preceding the tympanoplasty, resulting in good ventilation of the middle ear and aeration of it. In group 1, as already discussed, persistent perforation was seen in 3 cases, which is 30%, and complete closure was seen in 7 cases. In group 2, where we did septo and tympanoplasty, persistent perforation was seen in 1 case and complete closure was seen in 90 cases. 90%, which is 9 cases. And hearing outcome, the airborne gap gain in the study was higher in group 2. As already discussed, airborne closure of less than 15 in group 1 was seen in 80%. And more than 15 was seen in 20%. In septoplasty with tympanoplasty, group 2, airborne closure of less than 15 was seen in 90% and closure of more than 15 was seen in 10%. Subjective improvement in hearing, which the patient himself told himself or herself told that they have improvement in hearing. Sir?
1 minute left.
Oh, yes, sir. In group 1, 7 patients showed a significant improvement in hearing, and group 2, 8 patients showed significant improvement. 3 patients showed mild improvement, and 2 patients showed, in group 2, 2 patients showed mild improvement. Conclusion is that graft uptake in septoplasty preceding tympanoplasty was 90%, and tympanoplasty alone, the graft uptake was 70%. The success rate is more in septoplasty preceding the tympanoplasty, with AB gain reduced to less than 15 decibels in 90% cases. Therefore, septoplasty before ear surgery yields better results. These are my references, sir.
How did you classify the tympanic membrane perforations, pars tensa perforations?
So I got, pardon, sir? The retractions, are we talking
How
about?
did you classify? Whether it's
Based on
anterior, posterior, or what perforations did you compare with septoplasty
So
without
central perforations we have taken.
You didn't classify them. And was it a dry ear or a wet ear?
Dry ear, sir. Dry ear, 4 weeks
What
prior to the
tympanoplasty was done? 1, 2, 3, 4, 5.
type 1 tympanoplasty, sir, with underlay
Mention
technique
at
for
all.
1 cases. Sir?
You didn't mention at all.
We have tried to restore the hydraulic ratio in type
You
1.
didn't tell what tympanoplasty was done. What type of tympanoplasty was done?
So type 1 tympanoplasty, which is also known as myringoplasty with restoration of hydraulic ratio.
What sir is saying, in your study, you have not mentioned the type of tympanoplasty in all cases. You just mentioned tympanoplasty alone. You
Yes,
didn't
sir.
mention about the types of conductive hearing loss for each patient. You just mentioned that patient had a conductive loss, but you didn't mention it could be a
Yes,
type
sir.
1, type 3.
Actually, we
whatever.
were considering
And
based on the
and I think you have also not
ossicular reconstruction as well, but the patients which we have taken into the study didn't have any ossicular damage, so we did type 1 tympanoplasty, sir.
that was not mentioned one.
Yes,
And
sir.
have you mentioned about whether it's a cartilage or a fascia?
Sir? Fascia, sir. Temporalis fascia, I've mentioned it, sir. Underlay technique.
Okay, now you said that myringoplasty and tympanoplasty are the same. Is it so? What is the difference? What is the difference between myringoplasty and tympanoplasty?
Myringoplasty is reconstruction of the tympanic membrane with a restoration of hydraulic ratio, which is type 1 tympanoplasty.
What is the difference between tympanoplasty and myringoplasty? Is it the same or is it different? Why we can give the same name for type 1 tympanoplasty also?
We can give it the same name for type 1 tympanoplasty, but again, we are
You
reconstructing.
cannot give, but world does not accept. Okay.
Okay.
And
Yes.
why did you choose septoplasty? You would have chosen a FES with tympanoplasty. Why did you choose septoplasty?
So since septum deviations also like, might cause eustachian tube dysfunction because of the not proper aeration or nasal airway, improper airway might cause eustachian tube dysfunction. So I considered septoplasty as well, septoplasty in my study.
What investigation will you do for that? To know
If for eustachian tube dysfunction, sir?
Yeah.
Or we can do Valsalva maneuvers or Siegelization.
What
So
investigation? Not clinical. What
Clinical,
investigation?
Tonby maneuvers or Frenzel's
Investigation.
maneuver.
Investigation. I'm not
Diagnostic
asking
nasal
clinical
endoscopy, sir.
maneuvers. Huh?
We have done diagnostic nasal endoscopy as well to check the eustachian tube orifice patency.
Okay. Thank you.
Yes, sir.
Harsha, only one doubt is probably I didn't listen properly. Was the septoplasty and tympanoplasty done at the same time or it's different?
No, sir, with 6 weeks apart, sir.
Okay.
Septoplasty was done 6 weeks prior to the tympanoplasty.
Right. Thank you.
Yes. Thank you so much, sir.
Dr. G. Tanvi.
Yes, sir, I'm there, sir.
Share your screen.
I'm sharing my screen. Is my screen visible, sir?
Yeah.
Shall I start, sir?
Yeah.
Good afternoon, everyone. My topic for presentation today is a study of hearing results using pre- and post-operative pure tone audiogram in patients undergoing tympanomastoidectomy. Introduction. Chronic otitis media is a persistent infection of a part or whole of the middle ear cleft characterized by ear discharge and a permanent perforation of the tympanic membrane. Continuing mucosal infection of the middle ear by resistant organisms, nasopharynx with secondary infection of the middle ear cleft, and mucosal changes of the middle ear secondary to eustachian tube dysfunction may contribute to the development of chronic otitis media. Incidence of chronic otitis media is higher in developing countries. It is the most important cause of hearing impairment in rural population. Pure tone audiometry is a key hearing test used to identify an individual hearing threshold level, allowing the degree, type, and configuration of a hearing loss to be determined, and thus providing a basis for diagnosis and management. Pure tone audiogram is a non-invasive subjective behavioral measurement of hearing thresholds. The pure tone average is an average of air conduction thresholds at 500,000 and 2000 Hz speech frequencies. The difference between the thresholds of air conduction and bone conduction is called the air-bone gap, which is a measure of conductive hearing loss. So the basic principles of surgical management in a case of CSOM are to eradicate the active disease and thus promote drainage and healing in an ear with diffuse mucosal disease, to prevent recurrence of infection in an ear that has remained inactive by restoring an air-filled middle ear cavity lined by mucosa, to prevent the complications and to restore the function. So my aims and objectives. Aims are to evaluate the improvement in hearing in patients undergoing tympanomastoidectomy. The objectives being to assess the hearing status of a patient with central perforation, to estimate the prevalence of hearing loss in central perforation of tympanic membrane, to study the importance and techniques of various tympanoplasties in hearing improvement, and to determine the improvement in hearing status after tympanomastoidectomy. The type of study, it is a prospective study done in a tertiary care hospital in Telangana with a sample size of 100 patients and a study period of over a period of 18 months. The inclusion criteria, the patients included were in the age group of 16 to 65 years. Central perforations with active or inactive disease were taken, and traumatic central perforation is also included. It is active or inactive. The exclusion criteria being patients with atticoantral disease, previously operated ears or residual or recurrent diseases, CSOM with complications, tumors of the ear, congenital anomalies, and patients with moderate to severe sensorineural hearing loss. Detailed history was taken. Clinical examination was done, including otoscopy, otoendoscopic examination, diagnostic nasal endoscopy. Audiological assessment was done with pre and post-operative pure tone audiometry, and radiological assessment were done with X-ray mastoids and CT scan of the temporal bone. The results, the distribution according to the age, most of the patients were in the age group of 31 to 40 years, followed by 41 to 50 years. So the mean age group is 36 plus or minus 12 years. According to the gender, it was mostly seen in the females than males. So the sex ratio being 0.4:1 in males and females. According to the occupation, it was observed that majority, 66.7% of the patients of the study were farmers. According to the diagnosis, in my study, CSOM of the left ear was more common, 50%, followed by right ear, and bilateral CSOM was seen in 14%, and one case of traumatic central perforation was included. According to the perforation, most of the cases had a median central perforation in the anterior-inferior and the posterior-inferior quadrants. According to the type of surgery, type 1 tympanoplasty was done in 9%. Type 1 tympanoplasty plus cortical mastoidectomy was done in a maximum of patients of 81%. Type 2 plus cortical mastoidectomy was done in 8%. And type 3 tympanoplasty plus cortical mastoidectomy was done in about 2%. According to the graft used, temporalis fascia was used in 70% of the cases. Temporalis fascia with cartilage shield was used in 30%. This is the picture showing pre and post-operative pure tone audiogram of the left ear. The mean pre-operative PTA of the left ear was 46 plus or minus 15 decibels. Of the post-operative PTA of the left ear, mean was 28 plus or minus 9 decibels. The pre and post-operative PTA of the right ear, the mean pre-operative of the right ear being 45 plus or minus 17 decibels, and post-operative of the right ear mean being 30 plus or minus 11 decibels. The distribution this is the distribution according to comparison between pre and post-operative PTA. And in the right ear, there was a p-value of less than 0.003%, and in the left ear of less than 0.001%. So there was a statistically significant difference noted, suggesting that a significant improvement in hearing was shown. This is a comparison according to the graft material and the post-operative PTA. And in the right ear and the left ear, a statistically significant difference was noted, suggesting that temporalis fascia was better than temporalis fascia plus cartilage shield for both the ears. Discussion. Tympanoplasty is considered to be an otological surgery with the main advantage of recurrent infection of middle ear to improve hearing. Many studies have been carried out in the past regarding the structural and functional outcomes following surgery. Reconstruction of tympanic membrane was most commonly done with temporalis fascia. However, in cases of chronic eustachian tube dysfunction in adhesive process involved recurrent subtotal and total perforations, fascia with cartilage shield was used. Cartilage, due to its innate structural ability, has a more predictable shrinkage than the temporalis fascia graft. The hearing results were thereby influenced by the graft material used. The present study findings were similar to the previously conducted studies like Vaibhavi et al., in which the mean preoperative PTA was 42 plus or minus 10 decibels. It was similar to a study of Mahesh Babu et al., in which the preoperative PTA was 43.8. It was comparable to other study of Bhatni et al., in which the mean airborne gap was preoperatively 23 plus or minus 7 decibels. It was similar to a different other studies, and it is consistent with a study by Jain K et al., in which the temporalis fascia graft was found to have a greater uptake and a significant improvement in hearing. And it is similar to a study by Rahman et al., in which there was significant improvement with tympanoplasty and cortical mastoidectomy in terms of graft uptake and hearing outcome. So the conclusion, the present study was undertaken with an aim to evaluate the improvement in hearing in patients undergoing tympanomastoidectomy over a period of 18 months. Total patients of 100 patients were included. Following ethics clearance, the study has started. Results over the mean age was 36 plus or minus 12 with 71 females and 29 males. The mean preoperative PTA of the right ear was 45 plus or minus 17 and left ear was 46 plus or minus 15. All types of perforations were seen in the study. 81% of the subjects underwent type 1 tympanoplasty plus cortical mastoidectomy, with the graft being used 70% as temporalis fascia and with cartilage shield in 30%. So the post-operative PTA was 30 plus or minus 11 decibels in the right ear and 28 plus or minus 9 decibels in the left ear. An improvement in the PTA was seen in the study post-surgery, which was statistically significant for both right ear, which is with p-value of less than 0.003, and left ear with a p-value of less than 0.001. So the post-operative PTA levels were examined based on the graph used, and a significant difference was seen between them, showing temporalis fascia was better than the fascia plus cartilage shield. The limitations of this study are the small sample size. There could be an element of information bias in this study. Patients with post-operative residual perforations and recurrent diseases are not included. Atticoantral is not included. These are my references. Thank you.
Thank you, Dani. Question is that you mean that when the temporal fascia was better compared to fascia with cartilage, is it?
Yes, sir.
So you would not recommend the cartilage nephroplasty?
If the hearing improvement is the main goal, then temporalis fascia would be the better option, sir. But if prevention of infection and take-up is more important, then cartilage shield also can be used, sir.
Obviously, a patient is going to expect both, no? So what is your recommendation?
Sir, I couldn't hear you, sir.
Patient's expectation will be both, no? They will not say, I want only one.
Yes, sir. So if the
What is your
perforation is
recommendation?
yes, sir. So if the perforation is small or medium, then we can go with temporalis fascia, sir. But in large perforations or in chronic tear diseases with eustachian tube obstruction, and in those conditions, we can go with cartilage shield, sir.
What is the thickness of the cartilage? What is the thickness of the cartilage you use?
Sir, I can't hear you, sir.
What is the thickness of the cartilage that is used?
Sir, I'm not aware of the exact values.
That matters. That is why your
1 mm, sir. 1 mm.
1 mm. What is the thickness of the tempering membrane? Why is it important?
Sir?
What is the name of the investigation which studies the movement of the tympanic membrane?
Sir, I can't hear you, sir.
What is the name of the instrument that is used to find out the vibration of the tympanic membrane? Good presentation.
Pneumatic Siegel's speculum can be used, sir, to look for the vibration.
No. I am asking for investigation. It's okay. You've done a good job.
Okay, sir. Thank you, sir.
Dr. P. Susan Soundarya.
Yes, sir, I'm here, sir.
Yeah. You can start sharing your screen.
Can you see my screen, sir?
Yes, you can start now.
Okay. Good afternoon, everyone. I'm going to present a case series on bronchial asthma and chronic rhinosinusitis patients, a correlational study. Chronic rhinosinusitis and bronchial asthma are two diseases often coexisting. Many researchers have described the concept of one airway, one disease, saying that there is an epidemiological, pathophysiological, and clinical correlation of bronchial asthma and chronic rhinosinusitis. The influence and interaction between asthma and rhinitis exists with chronic rhinosinusitis, allergic rhinitis, and viral respiratory tract infections. Upper and lower airway mucosa are continuous, and the type of inflammation in chronic rhinosinusitis and asthma could be very comparable, related to T helper type 2 lymphocytes, eosinophils, and mast cells. Current evidence suggests that comorbid chronic rhinosinusitis may additionally have clinically applicable consequences on bronchial asthma. The prevalence of chronic rhinosinusitis is estimated to be between 22 and 50% among patients with asthma. Chronic rhinosinusitis is associated with more severe asthma, especially in patients with polyps. The aim of the study is to find the association between chronic rhinosinusitis and bronchial asthma. The objectives are to estimate the prevalence of bronchial asthma among patients with chronic rhinosinusitis, establish the concept of unified airway disease, and to assess the improvement of asthma after treatment of chronic rhinosinusitis. The study was done in a tertiary care hospital in Telangana. It is an observational study over a period of
from May 2022 to March 2024. The study population were all patients with symptoms of chronic rhinitis and rhinosinusitis, and the sample size was 100. The inclusion criteria were patients of either sex aged between 18 to 60 years, all cases of chronic rhinosinusitis with or without polyps, patients with rhinosinusitis with a history of bronchial asthma, and patients with sinonasal inflammation on CT paranasal sinuses. The people excluded from the criteria were patients less than 18 years, congenital disorders and genetic disorders related to the nose, post-operative patients of FES, sinonasal tumors, and patients with lung and cardiac pathologies. Methodology: after a detailed history and clinical examination with anterior rhinoscopy, the following investigations were done: diagnostic nasal endoscopy, absolute eosinophil count, serum immunoglobulin E, spirometry, and CT paranasal sinuses. The diagnosis of chronic rhinosinusitis was made based on the criteria given by European position paper on nasal rhinosinusitis and nasal polyps, with evidence of primary symptoms of nasal obstruction, blockade or nasal discharge, facial pain or pressure lasting for more than 3 months, with endoscopic evidence of nasal polyps or mucopurulent discharge or edema, and positive CT findings. The diagnosis of asthma was made based on the latest GINA 2024 guidelines, with the presence of asthma symptoms of wheeze, cough, shortness of breath or chest tightness, and excessive variability in lung function by positive bronchodilator responsiveness test. All patients with confirmed diagnosis of CRS received medical treatment for 3 weeks, and functional endoscopic sinus surgery was done. Pre- and 3-month post-operative spirometry was done to assess the improvement. This is a case of 2 patients with normal spirometry and moderate reversible airway obstruction. Quantitative data analysis was presented as mean, standard deviations, and standard errors. And the association between chronic rhinosinusitis and bronchial asthma was made with chi-square and independent t-test and paired t-test. A p-value less than 0.05 is considered as significant. Results. The maximum 42% of the patients were ranging between the age groups of 31 to 40 years, and majority were female, 61% in the study. 82% presented with nasal obstruction, 73 with nasal discharge, 33 with olfactory dysfunction, and 70% had facial pain. DNA findings: 92% had mucosal edema, 27% had polyps, and 68% had mucopurulent discharge. Of all the 100 cases, 27% of chronic rhinosinusitis patients had nasal polyps, and 29 patients with chronic rhinosinusitis had bronchial asthma, which was similar to the study conducted by Jose A. in 2023. Among the chronic rhinosinusitis patients with nasal polyps, majority, that is 59%, were having asthma, and this association was statistically significant. And among the 100 patients, the absolute eosinophil count was increased in 54% of the cases, and immunoglobulin E was increased in 47% of the cases. Pre- and post-operative lung parameters showed an increase in FEV1 percentage predicted value from 58.83% to 77.38, and FVC value from 84 to 90, which was statistically significant because p-value gotten was less than 0.05. Discussion: most of the patients ranged between 31 to 40 years, and most of the patients were females. The prevalence of bronchial asthma was 29%, similar to the study by Al-Ahmad et al. And among the 29 patients of CRS and bronchial asthma, 59.3 had polyps, which concurred with a study by Castillo et al. In the present study, FEV1 before and after improvement was from 58 to 77, and FVC percentage predicted was improved from 54 to 90%. The findings concurred with a study by Nair S. et al., in which pulmonary function test predicted scores improved post-treatment significantly. Conclusion: the bronchial asthma is the most common comorbid condition associated with chronic rhinosinusitis, and chronic rhinosinusitis with nasal polyps is associated with more severe asthma symptoms compared to without polyps. The concept of unified airway disease, saying that there is a common pathological process of both the diseases,
influencing one another. All the patients with chronic rhinosinusitis must be evaluated for coexisting bronchial asthma. This is of paramount importance, and all patients with CRS should undergo screening for bronchial asthma, and all patients with bronchial asthma must undergo a screening for chronic rhinosinusitis, because managing chronic rhinosinusitis could alleviate the asthma symptoms and improve the quality of life. These are my references. Thank you.
So what's new in your presentation?
Sir, the concept of unified airway disease has already been established, but I wanted to find out do this research in our institution, sir, and put emphasis on the fact that all chronic rhinosinusitis patients must undergo a screening for bronchial asthma, because it can improve the patient's quality of life and thereby alleviate their symptoms.
With polyps, after removing the polyps,
yes, sir.
With polyps and without polyps, how do you manage?
Sorry, sir?
With the polyps and
Yes,
without CRS, with polyps, without polyps, how do you
Yes,
manage in the presence of asthma?
So chronic rhinosinusitis with polyps and
Is
without
it the
polyps?
same, or you try to do something different?
So definitely chronic rhinosinusitis with polyps is associated with more severe bronchial asthma symptoms, sir. So they should, after clearing the
No,
disease.
there are a lot of people who say you should not do surgery. That's why I asked.
No, sir.
A
Like
lot of
in my
physicians say you
study,
can treat with medications.
yes, sir. But
So
the main aim
medication
of
becomes the same for both CRS with polyps and without polyps with
sir, in my
asthma.
study, I have
So how do you differentiate, or how do you make it better?
So in my study, I have gotten the same criteria, sir. The main aim of functional endoscopic sinus surgery is to create a pathway, to create a way for the drugs to enter the sinuses and restore the sinus drainage, sir, to clear the sinuses. So mainly the aim is to provide a proper drug delivery. So with polyps or without polyps, even the patients
So what do you
without
do
polyps.
with polyps? What treatment do you give for patients with polyps with asthma?
So so all the patients will receive intranasal corticosteroids treatment with antihistaminics, nasal decongestants, and antibiotics, sir. Along
So
with
you don't do
stress, to clear
surgery.
the polyps.
You don't do surgery.
We do surgery, sir.
So what is the difference? How do
So,
they better, or how do they fare?
sir, patients with polyps after clearance with the surgery fare better because they have more clearance for drug delivery. And we are removing the allergic or the infective focus. So the common inflammatory pathway is cleared, so patients have a better outcome of bronchial asthma.
How long was this patient followed up?
So 3 months post-operatively, sir.
So all these patients didn't have any recurrence of bronchial asthma in the 3 months, is it?
So some of them did have, sir. That is why I have shown only a mean improvement in the spirometry values.
And
Because we
post-operatively,
cannot
these
control
people
the
were also
trigger
followed up by
factors.
medications. Post-operatively also, these people were followed up with medications for 3
Yes, sir.
months.
Yes, sir. Post-operatively also, they received medications.
Okay. Thank you, ma'am.
Thank you, sir.
That's a good presentation, Dr. Susan Soundarya.
Thank you, sir.
Next, Dr. K. Vaishnavi.
Yes, sir.
Share your screen, please.
Is it visible, sir?
Make it full screen.
Is
Are
it
you ready?
visible, sir? Am I audible?
Yeah, visible. You can start
Can I
now.
start, sir?
Yeah.
Good morning, everybody. My case series is a comparative study on efficacy of a combination of nasal steroids and mast cell inhibitors against nasal steroids alone in the persistent adenoid hypertrophy in the pediatric population. Due to the adenoid importance for immunity in the early childhood and the risks of anesthesia and the operative complications, an alternate medical treatment has been considered with mometasone alone and in combination with a montelukast to alleviate the symptoms. Adenoids are a collection of lymphoepithelial tissue in the superior aspect of the nasopharynx, medial to the eustachian tube orifices. Adenoid size tends to increase during childhood, usually reaching maximal size by age 6 or 7 before regressing by adolescence. Viral pathogens associated with adenoid hypertrophy include adenovirus, Coxsackie virus, CMV, EBV, HSV, etc. Here we can see the Clemens et al. Endoscopic grading of adenoid hypertrophy, where in grade 1 there is less than 25% of choanal obstruction. In grade 2, there is more than like half, there is up to 50% of choanal obstruction. In grade 3, there is more than 2/3 of posterior choanal obstruction. And in grade 4, there's complete choanal obstruction. Many aerobic bacterial species have been implicated in contributing to this infectious condition, including Streptococcus, H. influenza, Moxarella catarrhalis, Staph aureus, and Neisseria. Multiple non-infectious causes of adenoid hypertrophy include GERD, allergies, exposure to the cigarette smoke, and also in adults, it can be a sign of more serious conditions such as HIV, lymphoma, or sinonasal malignancy. My aim is to study the efficacy of combination of mometasone and montelukast in persistent adenoid hypertrophy in children. Objectives: to evaluate if there is any reduction in the size of adenoid hypertrophy after 3 months of usage of mometasone singularly and in combination with the montelukast in pediatric population attending a tertiary care hospital. This can be evaluated with the help of diagnostic nasal endoscopy and giving a score for each symptom like snoring, mouth breathing, nasal obstruction, and size of adenoids. Materials and methods. Patients attending the Department of ENT outpatient and those who got admitted in the wards will be selected to study after taking informed consent from the parents, that is child assent, and privacy and confidentiality will be maintained during all stages. Inclusion criteria: age, children of age group 7 to 12 years, grading of the adenoids, grade 2 to grade 4. Exclusion criteria: those who are not willing to give consent, and in children whom steroids are contraindicated or who have previous history of allergy to above drugs, and the patients who are not willing for the follow-up. Methods: a total of 30 children aged 7 to 12 years diagnosed with persistent adenoid hypertrophy were treated in 2 groups. Group A, 15 patients received combination therapy of mometasone in the form of nasal spray and montelukast in the form of oral tablet. Group B consisted of 15 participants which received mometasone alone. Duration of the treatment was around 12 weeks. Dosage: mometasone 1 puff in each nostril once a day, montelukast 5 mg once a day. Mometasone is a medium potency synthetic corticosteroid which acts on mast cells, eosinophils, neutrophils, macrophages, and other inflammatory mediators like histamine, phospholipase A2, leukotrienes, and creatine kinase. Phospholipase A2 releases arachidonic acid, which is an inflammatory precursor. Mometasone induces phospholipase A2 inhibitory proteins and controls the release of arachidonic acid. Dosage in 2 to 11 years, 1 spray each nostril, which is equivalent to 50 micrograms. Total daily dose is 100 micrograms. In adults, 2 sprays each nostril, dosage is equivalent to 200 micrograms per day. Montelukast is a leukotriene receptor antagonist, which is released by mast cells. Human cystinyl leukotriene receptor 1 is elevated in the adenotonsillar cells and tissues, which may be involved in the pathogenesis of adenoid hypertrophy. So montelukast is an effective cystinyl LT receptor antagonist. Dosage in 6 to 14 years is 5 mg per day, and in greater than 14 years, it is 10 mg per day. Outcome measures: nasal obstruction, mouth breathing, snoring, and adenoid size reduction. Results are based on the symptom scores. Table 1 shows pre-medication and post-medication scores of nasal obstruction. Reduction percentage in combination group was around 58% after the usage of medication for 3 months. And in group B, that is mometasone alone group, the reduction percentage was around 35%. Table 2 shows mouth breathing scores. Reduction percentage in combination group was around 59%, and in group B, it was around 48%. Table 3 shows scores of snoring, pre-med and post-med. Reduction percentage in combination group was around 62%, and in group B, it was around 43%. Table 4 shows the comparison of adenoid size, pre and post-med. In group A, reduction percentage of size of adenoid hypertrophy was around 50%, and in group B, it was around 35 to 40%. Discussion: in a meta-analysis by Chauhan et al. Regarding the effects of intranasal mometasone in children with adenoid hypertrophy, results showed that mometasone effectively reduced adenoid size and other symptoms. Several studies have evaluated the effectiveness of montelukast, which is an anti-leukotriene, as an anti-inflammatory agent in this condition. In studies of Goldbart et al., Shokohi et al., and Tyrandish et al., the improvement of symptoms by montelukast alone also has been reported. Conclusion: this case series indicates that combination therapy was much more effective in alleviating the symptoms, as it has significantly showed greater reductions in the nasal obstruction, mouth breathing, snoring, along with improved quality of life and adenoid size reduction, suggesting that it may be the preferred approach for managing this condition. These are my references.
Yeah, good presentation, Vaishnavi. How long was this nasal spray given?
Sir, 3 months, sir.
3 months. And even montelukast, I mean, the other tablet also was given. That was also
Yes,
given
sir,
for 3 months.
Yes, sir.
Right. Thank you from my side. Yeah. Hello, Shankar sir.
Shankar sir, any questions?
Why did you choose montelukast? Why did you choose montelukast?
Because there
You
is a
can choose antihistamine, anything, but why did you choose montelukast?
reports have been shown that a human cystinoid leukotriene receptor, which was involved in pathogenesis of adenoid hypertrophy, and montelukast was effective against that receptor.
How did you know that the adenoid hypertrophy was because of allergy?
Sir?
How did you know that the adenoid hypertrophy was not because of infection?
Because of the expression of the...
No, see, adenoid hypertrophy, when you think of enlarged adenoid, what do you think?
Would be viral infections primarily.
Infection. Why did you choose steroid for this long, or steroid with montelukast? On what basis did you choose?
Might be helpful in patients who are not fit for surgery.
The criteria.
Like in patients
You say might be. You have to tell me the criteria for which you have used this particular combination or this particular drug.
It might be helpful in patients who are unfit for surgery, sir, like in patients who have palatal insufficiency.
That you have already excluded. No patient was not willing for surgery. What are the others?
Then medical treatment.
Okay. Thank you.
Okay, thank you, K. Vaishnavi. Nice presentation. Dr. Nauma Sarin, R. Geetanjali, L. Nagaraju, S. Kavya. Any one of you present here? Okay. Sir, we got information that the serial number 19, 20, 21, and 22, they are not presenting, sir.
Okay, sir.
Thank you, sir.
And we will be calling upon the presenters from the previous session who have missed because of technical disturbances.
No problem.
Dr. T. Divyarani.
Number.
Serial number 3, Dr. T. Divyarani.
Yes, sir. Present, sir. Sir,
Are you
hello,
ready?
sir. Yes, sir.
Yeah, please share your screen. Serial number 3.
Sir, is it screen visible, sir?
Yes.
I'm made into a slideshow, sir.
Yeah, make it slideshow.
Yeah, sir. I have made it.
Okay, continue.
Full screen.
Okay. Full screen, sir. It is done, sir, on my screen.
Okay,
Yeah,
it's
thank
okay.
you.
You can continue.
Okay, sir. Starting, sir.
Yeah.
Good afternoon. This is T. Divyarani. I'm going to present about suicidal cutthroat injuries, a study on 20 cases. Background: suicidal cutthroat injuries are self-inflicted injuries of anterior neck. It is observed in patients with alcohol intoxication, substance abuse, or with major psychotic depression. Mostly observed in zone 2, and injuries may range from minor superficial injuries to penetrating laryngeal injuries. Tracheostomy should be done in patients with laryngeal fracture, stridor, or elevated breathing effort. And neck trauma patients should also be examined for cervical spinal injury if there is any adverse
Excuse me, doctor.
sensorium.
Excuse me. We are not getting your slides.
It
Sir,
is
I'm
not moving.
sharing, sir.
It is not moving.
Sir, it is a third slide I'm showing, sir.
We are
There is
getting
only
first
one
slide.
first slide alone.
Your introduction slide.
Sir, now is it visible, sir?
Yeah.
Yes,
And
okay, I'll
full
not
screen.
make slide. Full
Can you
screen.
make it full screen?
Yes,
Full
sir.
screen.
Made,
click on
made, sir.
slideshow. You click on
Full
slideshow. We
Slideshow
are
I
not
made.
getting.
I made
I
it,
think
sir.
your internet connection is poor.
Yes, sir.
It's okay.
In the morning
Continue.
also
Let her
this
finish
one,
that.
yeah.
Okay, carry on.
Yes. I'll, yes. A pharyngogenous fistula must be prevented as much as possible while carrying out hypopharyngeal repair. An injury to airway tract leads to stenosis and web formation, and injury to major vessels can cause death from hemorrhage, shock, or ischemia. Aims of my present study is to find the influencing factors proven for suicidal cutthroat injuries, and to see the vulnerable age group and sex for suicidal cutthroat injuries, and to know the depth of injuries and repair options available. Materials and methods. Type of study is a retrospective study conducted in our institute for a period of 6 months, and sample size is 20. Inclusion criteria: patients with suicidal cutthroat injuries were taken, and above the age of 15 years were taken. And exclusion criteria: patients with cutthroat injuries due to other causes such as RT and assault were excluded. These patients were admitted, investigations were done, and immediate surgical expiration and repair was done. Patients were followed up for a period of 2 months and assessed for postoperative complications and recovery rate. And results: based on a study, we have found that male sex predominance was observed. There were 18 cases out of 20, and age incidence: most of the patients were under the age group 26 to 35. There were 9 patients, and there were 0 patient in the age group greater than 55 years. Under the influence of addiction, most of the patients were under alcohol influence. There were 14 patients observed, which accounted for 70%, and non-alcohol influence, there were only 30%. Based on the objects used, 50% of patients were used blade, and 30% knife, and other objects used were glass and beer bottle and other objects. Based on zones of neck, zone 2 was mostly involved in most of the cases. Almost 17 cases, zone 2 was involved. Based on the depth of anterior neck injuries, 65% involvement of skin and superficial layers was seen, and strap muscle involvement 45% was seen, and 25% laryngeal cartilages were involved. There were 0 cases with esophageal injuries. Based on the clinical feature, most of the patients had pain and tenderness, 60%, and active bleeding was found in 10 cases, which accounted for 50%, and respiratory distress was seen in 25% cases. Chronic illness index: based on this, there were immunodeficiency patients, there were only 2, and diabetic patients, there were 3, and hypertensive patients, there were 2. psychiatric illness, 16 patients were with non-psychiatric illness, and there were 4 patients with chronic psychiatric illness. And based on the types of cuts, clear anterior cuts were seen in 11 patients, and 2 cases had hesitation cuts in other parts of the body, and irregular incisional cuts were seen in 7 patients, which accounted for 35%. And surgical treatment provided was mostly simple wound closure for superficial injuries, and repair of larynx with tracheostomy was done in 6 cases, and repair of hypopharynx was done in 3 cases, and pharyngocutaneous closure was done in 1 case. And medical treatment provided was in almost all the cases we have given psychiatric consultation and supportive treatment, and O2 support was given in 8 cases, and tracheostomy care was needed in 6 cases. And follow-up rate was 70% in ENT and 40% in psychiatry OPD. There was not 100% follow-up was seen, and recovery rate was good. Like 7 patients recovered within 5 to 10 days, and 8 patients they were greater than 10 days they recovered, and there were 6 patients with post-operative complications such as secondary site wound infection and surgical emphysema, and also pharyngocutaneous fistula, and 2 deaths were observed. Discussion in our study, majority of patients were males and most in the age group of 26 to 35, and the superficial cut throats, which were 13 cases, they required simple primary wound closure. With regard to the deeper structures, strap muscle involvement was 45%, laryngeal structures 25%, hypopharynx 30%, and cricotracheal injuries were 15%. And these deep injuries then required surgical exploration of the neck, and vascular injury, repair of vessels was done. And basically in a study, 6 out of 20 cases, they required tracheostomy. But in a study by Rao et al., there were 50% cases required tracheostomy. This is superficial injury where only skin and subcutaneous tissue was involved. We did simple wound closure. This is a case where deeper structures were involved. We did neck exploration with tracheostomy is done. And a study by Moin et al. Showed financial burden and marital disharmony were the principal reasons of the cutthroat injuries. But in our study, mainly alcohol dependence and withdrawal symptoms, psychotic disorder, and depressive disorder were mainly responsible. And even family history of suicidal behavior, impulsivity, old age, chronic illness, diverse, widowed are some of the socio-demographic risk factors found. And also, it was estimated that 100% patient, 20 cases require psychiatric consultation to treat and to avoid future tendencies of suicide. And our study had a mortality rate of 10%, which is higher than the rate quoted by in a study by Manin et al. Assessment is by assessment of this patient begins with ABCs of resuscitation. We do like checking the airway, evaluating the breathing as well as circulation. Anesthetist secures a compromised airway and breathing, and ENT specialist does surgical repair of the injured tissue, restoration of breathing, swallowing, and phonation. Whereas psychiatrist provides counsels the patient regarding psychiatric issues. This is a 3-tier management which is required in cutthroat injury. Mental illness are the strongest predictors of suicide. Depression, alcoholism, and other causes like schizophrenia are common mental disorders. And in patients with psychosis and schizophrenia, we found deeper cuts and more violent injuries were observed, whereas hesitation marks were more pronounced in patients with other depressive disorders. And basically, in the assessment of suicide attempters, building a rapport with the patient is important because they are reluctant in giving a history, and sometimes they lie about the history also. And taking a psychiatric history, we have to find the intent of suicide. And psychiatric management, especially important in suicidal cutthroat injuries, it requires counseling and medical management with various antidepressants and antipsychotics. And these patients are followed up, and also they are assessed to know the suicidal risk. Limitations in our study was our sample size was limited, and the history given by the patient and attenders, we had to rely on the history given by this patient and their attenders, because sometimes they give false information regarding substance abuse and addiction, and there was irregular follow-up, and so psychiatric evaluation and post-operative complication evaluation was also limited. There were only 14 cases which were followed up in ENT OPD. And conclusion is these are one of the suicidal cutthroat injuries, which is one of the major cause of mortality and morbidity, and these are mostly found in zone 2 of anterior neck, and interdepartmental effort is required. They are mostly seen in males and between age 26 to 35 years under the influence of alcohol. It could be controlled by increasing the emergency health services, awareness among public regarding mental health, and de-addiction centers, and socio-economic growth. These are my references. Thank you.
Good presentation, Divya. What is your ENT relevance in this?
So basically, we wanted to find out the predominance of age and sex, which is involved in suicidal cutthroat injuries. And we have we have found that greater than 50 years, there were no suicidal cutthroat injuries were seen. And even hesitation marks were also seen in other parts of the body in patients with depressive disorder. And we wanted to see whether interdepartmental correlation, how the interdepartmental effort is required, sir, and how to decrease the incidence of and frequency of suicidal cutthroat injuries, and to decrease the morbidity and mortalities.
What is your follow-up with these patients?
Basically, we have followed up only 14 patients in ENT OPD, sir, and 8 patients in psychiatric OPD. Basically, most of the patients were sent to de-addiction. Most of the patients were under alcohol influence, sir. So they have been given counseling and de-addiction management also. Some patient had 2 patients had depressive disorder and 2 patients had a psychotic disorder, sir. They were given a proper follow-up and medical management in psychiatric OPD, sir. And in ENT, we had post-operative complications of surgical emphysema, sir. We inpatient, we had followed up the patient, sir, right? And surgical site infection was also seen.
What was the antipsychotic medicines given for these patients?
Basically, suicidal tendencies, clozapine was given and olanzapine was given.
How long was it?
1 month clozapine and 3 months clozapine was given, sir. And it is followed by aripiprazole was also given.
Any tracheostomy complications you had for these patients?
Basically, afterwards, we had a little bit of wound site infection, sir. Surgical site infection. There was one pharyngocutaneous fistula, which saliva was leaking from the tracheostomy site, sir.
Okay,
So
thank you.
Yes, sir. Thank you, sir.
What is the classification for laryngeal injuries?
Sir, basically for anterior neck, we have divided into zone 1, zone 2, and zone 3.
No, that's neck injuries. Laryngeal injuries, how do you classify them? In this case, was there any injury to the larynx?
Yes, sir. The cartilage, thyroid cartilage was involved, sir.
So how do you classify them and how do you treat them?
Sir,
Did you classify the neck injuries according to the larynx?
No, sir.
You said
According
it's
to
mid-zone, zone 2. That means
Yes, sir.
larynx will be affected. You said
Yes, sir.
there is a pharyngocutaneous fistula. Pharyngocutaneous fistula is not from tracheostomy. Pharyngocutaneous is above.
Yes,
And
sir.
you said, you said laryngeal injuries, tracheostomy. What classification will you follow, and what grade or what level was the injury to produce difficulty in breathing? You had 24 cases. 24% of the cases had difficulty in breathing, from what I saw. So that 24% of patients who had difficulty in breathing, did you do tracheostomy? What was the incidence of tracheostomy?
Tracheostomy was done in 6 cases, sir, out of 20. There was a leak near the thyroid cartilage, sir. To reach near thyroid cartilage, we sutured it and we did low tracheostomy, sir, little.
Yeah, so you should have classified the laryngeal injuries.
Laryngeal, according to the laryngeal injuries.
What is the name called?
Sorry, sir.
Okay. So all the patients are fine?
Yes, sir. There were deaths seen in 2 patients, sir.
Okay.
And
So
others were followed up, were good, were fine, sir.
They're all on antipsychotics.
Yes, sir. 2 patients were on antipsychotics, sir. And under alcohol influence, they were given proper counseling and de-addiction management was given, sir.
Thank you.
Thank you, sir.
Yeah, thank you, Dr. Divya Rani.
Thank you, sir.
Next, Dr. Shravan Kumar, G. Shravan Kumar.
Number, sir?
Serial number 14.
Good afternoon, sir. Yes, sir. Shravan Kumar, sir.
Serial number 14, sir. 14. Dr. Shravan, are you ready?
Yes, sir, I'm ready, sir.
Share your screen.
Yes, sir.
Please take your laptop.
Sir, actually, there is a glitch in my laptop, sir. It is not connecting. I'm extremely sorry for that. Yeah.
You are not visible to us.
Sir, am I visible, sir?
Yeah, you are visible. Share your screen.
Yes, sir. Sir, is my screen visible, sir? Yes, sir.
Yeah, continue.
Yes, sir. Good afternoon, sir. The topic for
Visible,
today's
you are
case
not
is,
visible, Shravan.
sir.
You are not
Now
visible.
you are not.
Sir, sir, am I visible, sir?
Yes.
Yeah.
You're doing something wrong to.
Yeah.
But
Yesterday we
carry
have
on.
given clear instruction. Please
sir.
kindly log in only laptop or desktop. You are not following.
Yes, sir. I was
As
trying
per
to
the
connect
judge's
from
discussion, you
laptop,
go
sir.
ahead.
I'm sorry, sir. Yes, sir. Sir, the topic for today's case series is study of video nystagmography findings in patients with vertigo, sir. Coming to the introduction part, among 100% cases of dizziness, almost vertigo contributes for 54% of the cases, as per some studies, and still it could be more. And the diagnosis of vertigo, it needs a comprehensive evaluation. So we require a detailed history, which should be followed by the clinical evaluation, and they requires the audiological, radiological, and computerized tests. So if we see various computerized tests, there are electronystagmography, video nystagmography, rotational testing test, and computerized dynamic posturography and WEMP testing. So among these, today the topic for my presentation is video nystagmography, which I have conducted in 40 patients. So this, what is a video nystagmography? It is a complete diagnostic system for recording, analyzing, and reporting the eye movements using video imaging technology. Here we are using high-tech video goggles with infrared cameras. So what are the advantages of video nystagmography? So what does it conclude? It consists of, so video nystagmography includes a series of tests, and they will determine whether vestibular pathology or a central pathology is causing the vertigo. And video nystagmography, it helps document either there is a unilateral vestibular dysfunction or bilateral vestibular dysfunction, and it can confirm benign paroxysmal positional vertigo and central lesions also. So this video nystagmography, as I mentioned, there are series of tests in VNG. So these series of tests are the which tests for spontaneous nystagmus, gaze nystagmus, positional nystagmus, and there is saccade testing and smooth pursuit testing and optokinetic nystagmus and testing vestibulo-ocular reflex, and even if I can go for the caloric testing. So what is the aim of my study is to study the findings of video nystagmography in patients with vertigo. So what are the materials and methods I have used? So this is a prospective, observational, and cross-sectional study, and it was done on the patients attending to ENT OPD with a positive history of vertigo from August 2023 to August 2024 in a span of 1 year. So these 40 patients, and written informed consent was taken from the study participant, and detailed history is taken, and complete clinical examination as well as specific tests like hearing assessment and many other radiological tests has been performed. And finally, the patient is taken to the video nystagmography, and video nystagmography is performed in these patients, and the findings are studied. And those patients who were considered as diagnosed as central vertigo, they are referred to the neurologist for the further intervention. And inclusion criteria. So all the cases above 18 years and below 17 years of age which are presenting with vertigo has been included with some exclusions like acute neurological conditions and road traffic accidents and significant defective vision and claustrophobia. These are the conditions the patients were excluded. And this is the video nystagmography that we performed in our institute. So it consists of infrared goggles through which the patient will eye movements will be recorded in the system, and there will be requirement of 2 monitors. In one monitor we will see the eye movements, and in the other monitor it will give specific instructions like as suckered, and to check for the spontaneous nystagmus, and to check for the positional nystagmus and suckards and this optokinesis. All this can be processed, and it will give a printout of the report. And this by interpreting this report we will see various findings like abnormalities of the smooth pursuit or optokinetic movements, or any gaze nystagmus is there. So these findings we can see and we can document. So coming to the results of my study, so total among 40 patients, males were 22 and females were 18, and the number of patients of the age group 41 to 50 years or more, almost contributing to 13 patients, and 6 patients were from the age group of 18 to 30, and 9 patients from 31 to 40, and 13 patients from 41 to 50 as I mentioned, and 5 from 51 to 60, and 7 from 61 to 70. So these are the gender distribution. And coming to the comorbidities of this 40 patients, so among those 40 patients, 9 were hypertensives, 3 had diabetes, and 4 patients has hypothyroidism, 1 patient had epilepsy, and remaining 23 patients had no other comorbidities. Next, coming to the etiology. So based on this video nystagmography, among 40 patients, 17 patients were diagnosed to have peripheral vertigo, and 18 patients were diagnosed to have central vertigo, and 3 had this psychogenic or functional vertigo, and 2 the cause based on exclusion, and the patient had comorbidities hypothyroidism, and hypothyroidism can also cause either dizziness, vertigo. So 2 patients were included under the etiology hypothyroidism. So coming to this summary of VNG findings in this all patients. So 18 patients were diagnosed with the central vestibular disorder. So among them, if we see, abnormal saccades was the most consistent finding. So among 18 patients, almost 11 patients had abnormal saccades. But abnormal saccades can also be seen in Meniere's disease or vestibular neuritis sometimes. Here abnormal saccades has been contributing more to this central vestibular disorder. And next in BPPV, benign paroxysmal positional vertigo, there is a positional nystagmus is present most of the times, and there is a positive Dick-Salpike test as we already did. And Meniere's disease, the patient had abnormal optokinetic nystagmus as a consistent finding, because among 5 patients, 4 patients had abnormal optokinetic nystagmus. And next coming to the vestibular neuronitis. Vestibular neuronitis has all like abnormal smooth pursuit, abnormal saccade, and static positional nystagmus, positive Dick-Salpike also seen in 1 patient. So vestibular neuronitis cannot be fully diagnosed by this video nystagmography, but for confirming vestibular neuronitis, we can go for the caloric testing, and we can see the function of the labyrinth on that side. Next, coming to the psychogenic dizziness, the patient had same optokinetic nystagmus, but could be the performer error or the subjective or objective error. But mostly for if patient is considered for psychogenic dizziness or hypothyroidism, the patient findings all will be negative. Among this, if there is an abnormal saccade, we can contribute it to central vestibular cause. If there is an abnormal positional nystagmus and positive Dick-Salpike, we can go for the BPPV. And if there is an abnormal optokinetic nystagmus, we can consider for the Meniere's disease. So these are the findings in video nystagmography. So based on video nystagmography findings, the final diagnosis could be 18 are the central vestibular disorders, 5 Meniere's, 9 BPPV, 2 vestibular neuronitis, vestibular migraine 1, psychogenic 3, and hypothyroidism. So these are the results of my study. Coming to the discussion, among all the 40 patients, males are more, as we discussed, when compared with the females, and most common age group was 41 to 50 years. And among all these patients, tinnitus was the most common complaint. It was seen in both central as well as peripheral vertigo. So that was the finding. And among 40 patients we have studied, 26 were positive for the tinnitus. And among this peripheral vertigo patients, almost 3 patients had unilateral SNHL, sensory neural hearing loss. And next is among all the patients, optokinetic nystagmus was the most common abnormality we have seen. And this most common abnormality, optokinetic nystagmus, was attributed to the Meniere's disease. And if there is a central vertigo, as we discussed, there will be abnormal saccades, and there will be abnormal smooth pursuit findings. So finally, I want to conclude this VNG has come out as a very useful test in aiding almost 75% of the diagnosis. And but there will be some abnormal findings, some may not fit into the clinical scenario. So we have to correlate both clinically as well as with our audiological investigations, and if required radiological. And we should go for the video nystagmography. And based on all these findings, we can conclude one diagnosis. Yes. Yes, sir, fine. So abnormal saccades seem to be more relevant findings in central disorders. So the overall benefits are immense, and it will necessitate their inclusion in every vertigo clinic. Yes, sir, these are my references. Thank you, sir.
How many? Sir, he has crossed his time limit, sir. No questions allowed, sir.
Okay.
Yes, sir. Sir, Funny, any remaining candidates? Please read out their names.
Dr. Nikhil Kumar. Dr. Nikhil Kumar, serial number 16. Dr. Nikhil Kumar. Sir, I think he's not there here, sir.
That's it?
Yeah.
Yeah. Thank you so much, respected judges, Shankar sir and Somo Lakshmanan sir, for your
Thank
time
you,
and
sir.
patience.
Thank you, sir. Sorry for 1 or 2 minutes delay from my side.
No issue, sir. Yeah, sorry for troubling you. You are in an emergency case at that time. Yes, sir.
Thank you.
Thank you,
Overall, the
sir. Thank
presentation,
you.
everything was
Nice
fine,
of you,
sir.
sir.
It's a good presentation.
Yes, sir.